Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, October 7th, and it is time to do another IC support group. Now, my purpose with these live support groups is to give patients education, knowledge, support, encouragement, everything that you need so that you can walk into any doctor's office strong, informed, powerful, ready to have a really good discussion about your health care. Right, so we're going to do a support group meeting today, and we are simulcasting live on YouTube and on Facebook. And let's just take a couple of minutes to let people come in. Hello, JJ. How are you today? Hello, Facebook. So I'm sorry I started a couple minutes late. The reason we started late is because today is the anniversary of the giant fires that we had in Santa Rosa, California last year, where about 5,000 homes burned. And would you believe it? We are under another fire alert with almost exactly the same conditions. Our internet was down and our power was out last night. So if I disappear suddenly, that just is because we've got really big wind and bam, the power has gone out again. All righty. So I hope that you guys are having a really good day. I hope, I'm telling you, I love fall. It's a wonderful time of the year. I am, as we're talking, just setting up my desktop a little bit because I was running a little bit behind. Hello, Catherine. It's nice to see you. JJ, I hope you had fun last night. I don't know if you were playing or not. I was not. I had no power. Alrighty. So I want to talk a little bit about, hey, Catherine, if you can let your IC friends know, it'd be really, really great over on Facebook. I have something that I want to talk about today before we start taking your questions. And of course, I'm really, really happy to take any questions that you might have. Just write them in your comment area. Hello, Karen. Hello, Brenda. Hello, Erin. It's very, very nice to see you. So I think, most of you know that I've been working with IC for 25 years. I run the IC network. We're the largest IC support group in the world. In fact, I sit on the U.S. Army IC research panel, and I got my assignment last Friday. So October is dedicated to IC research here in my office, which is cool. I wish I could tell you more about it, but I have a confidentiality agreement, so I'm not allowed to do that. But let me just tell you that October is a very exciting time of the year for us. We finished IC Awareness Month. Now we're diving into really good IC research studies. But still, every day I take a lot of questions from patients, and I want to talk about something that I think patients really, really struggle with, and that is describing your pain. Because until you can describe your pain, you're not going to be able to give that doctor the clues that they need to diagnose you correctly, right? So your ability to be detailed, your ability to talk about locations, your ability to talk about nuance, your ability to talk about weird, unusual symptoms is so important. But one of the things that we see patients struggling with the most, that I see patients struggling with the most, is differentiating between internal and external pain. Hello, Stephanie. Hello, John. Hello, Malia. Hello, Donna. Nice to see you on Facebook. So when a patient calls my office and you want to do a coaching session, or you just want to ask a couple of questions, one of the very first things I'm going to ask you is, when is your pain the worst? Before you pee or after you're done peeing? Because if you have pain as your bladder is filling with urine that is relieved by urination, then that points to the bladder wall. If you have pain after urination, that points more to the pelvic floor or bladder spasms. But there's another nuance in there, and that is your pain internal or external? A lot of patients are mistakenly thinking that when they have what we call urine burn, that's part of IC, and it's not. So urine burn happens when, especially in women, when you're peeing and your vulva burns. It's like your urine feels hot. It feels unusual. It almost feels like infection. But there's a heat sensation. That, my friends, is not coming from your bladder. That is really about the quality and health of your skin. And so in a woman, when we see a lot of pain after urination, or if we see pain as urine is dribbling down across your urethra, across your vulva, that's really not IC at all. What that means is that your vulva is not able to defend itself well. That there's something that the skin, the quality and health of your skin is compromised in some way. Now, how is it usually compromised? It's usually compromised by estrogen loss. You know, estrogen is what helps make your skin thick and moist and resilient. And when you think about the bladder and you think about what we call your mucous membrane organs, and so that is your bladder, that is your urethra, that is your vulva, that is your vagina, and that is your mouth. These structures rely on a layer of mucus to protect themselves. And when that mucus is compromised, that skin is more vulnerable. Think about it. When you get dry mouth, it hurts, right? So what do? You drink water because moisture helps, right? Well, when you have dry vulva and dry vagina and dry urethra and dry bladder, it hurts. It hurts. And you're going to hear it most you're going to feel it the most when you're peeing. All righty. So as you're thinking about your pain, I want you to try to be as specific as you can. Is your pain internal? Is your pain external? What does your pain feel like? Is it sharp? Does it feel like you've been shocked by electricity? Or is it dull and achy? Where is it located? Is it to the center? So I'm going to stand up right here. All right. So this is the center of my body, right? Okay. So is your pain directly over your pubic area, or is your pain to the left, or is your pain to the right? Okay. Is your pain low? Is your pain high? These are important. As an example, some people talk about getting low back pain. And that sharp low back pain actually is often a sign of a very tight psoas muscle, which is a pelvic floor muscle, right? So if it's centered, that points to the bladder. If it's to the left, is it to the right? That's really going to point more to muscles. But I also want you to pay attention to nuance. What makes it better? What makes it worse? If bending over or squatting down or laying down or laying on your left side or the right side makes it worse, that's something that your doctor needs to know, because oftentimes it's these little tiny subtle changes in pain that will help a doctor really finesse why you're in pain. Okay. So as an example, for me, with my tight levator muscles from my surgery, my biggest challenge is laying flat on my back. If I lay flat on my back, I will have a very quick fluttering, because that's my pelvic floor muscle being stretched. That's my levator ani. That's my piriformis muscle and levator ani being stretched. If I tilt one leg out or one knee out, it's going to trigger it. And I'm still really trying to figure out what the triggers are. In fact, I'm going to a new physical therapist on Wednesday because I'm very, very frustrated with this whole thing. So you got to pay attention to your nuance. And then also, I really need you to understand your anatomy. You please don't go to the doctor and say it hurts down there. Come on, guys. You can do better than that. You need to say, it hurts in my urethra. It hurts in my bladder. And a big part of that, and although this shouldn't be controversial at all, there's certainly also a group of patients who have really never looked at themselves. And if you hurt externally, you need to be able to describe where you hurt externally. Is it your vulva? Is it your perineum? Is it your rectum? Is it your urethra? Is it your clitoris? And if you haven't done it, seriously, I want you to get a mirror. I want you to put it in the bathroom. I want you to drop your pants, and I want you to look at yourself so that you understand, especially if you're having pain externally, because you can then look at the color. Look at the quality. Are there any bumps? Is there any change in texture? Anything at all like that? That's all going to help you as you work with your doctors. Okay. So your ability to talk about your body, your ability to describe what you're feeling, your familiarity with how your body normally works is just so incredibly important. And there's no shame and there's no blame. I don't want you, I mean, there's definitely a population of patients who feel like, especially my mother's generation, you just didn't talk about it. You did not talk about it. And there's still a group of women and men who go to the doctor and the doctor says, "How are you?" And the woman will say, "Fine." And the woman literally cannot even describe the parts of her body. So I don't want you to do that. I don't want you to hide anything. I want you to be as clear and as specific as you can be. So is your pain internal? Is your pain external? Is it to the left of center? Is it to the right of center? Is it low to high? Is it low? Is it high? What is the quality of the pain? Is it sharp? Is it dull? Does it ache? Does it burn? Some people mistake burning as a bladder symptom. And believe it or not, burning is more of a pelvic floor symptom. Bladder wall pain tends to be very sharp and shrill. It feels like ground glass sometimes, or razor blades as your bladder fills. Pelvic floor muscle pain tends to be lower. It tends to be lower in the belly. It tends to be achier. It tends to be steadier. Bladder wall pain will vary as your bladder gets full. Your pelvic floor tends to be a little bit more steady. All right. So that's my little educational piece for today is try to be as specific as you can be. And let's go ahead and see if we've got any questions. Hello, Julianne on YouTube. Hello, Julie on YouTube. Hello, Amy on YouTube. All right, guys, hit me up with your questions. I am happy to take them. Aaron says, I feel like most doctors underplay one's pain. You know what? I completely agree with that. You have to understand that a doctor's frame of reference is their own personal experience, right? And if they've never had bladder pain before, they seriously don't know what it feels like. They have to rely on their medical school training to give them kind of a reality check because they've never had it themselves. In fact, there's only one doctor in the country that I know of who actually tried to feel what bladder pain felt like. And I won't say who he was, but he's a very top IC doctor. He actually put protamine in his bladder with a catheter to see how long it would last, how he could last. And he was crying and done after a minute and emptied it out. And from that point on, that doctor had tremendous respect for patients struggling with bladder pain. But the vast majority of doctors really have never had bladder pain before. So again, your ability to describe it, your ability to, one of the things I often say to patients is you have to talk about functions. How does your pain change your ability to function? That's a way to get through a doctor who might not understand. So if you say, doctor, listen, I can't go to church. I can't get in the car. I can't sit in the car more than a minute before it hurts. Or I can't get up and take a shower. I have one patient that I've worked with who has a very complicated case, not just IC, but also some nerve damage from something else that happened. And she would go weeks at a time without being able to take a shower. Okay, but again, that was not just from her IC, that was other things. So if you focus on your functions, that's a good way to tell the doctor how the pain is limiting you. One of the mistakes that patients sometimes make is you go into the doctor's office and you ask for pain meds. And you will look like a pain seeker, a drug seeker, if you do that. Instead, what you have to go in a really clever way, but a correct way of talking about pain control with doctors is to say, doctor, I am not able to do the things that I need to do to support my family and to live my life. I need to be able to work. I need to be able to buy food. I need to be able to fix dinner. I need to be able to come to the doctor's office without crying my eyes out. When you talk about functioning, the next question is, okay, what can we do to improve my ability to function? And that's when the doctor will often go, maybe you need to try a little bit of pain medicine. Maybe with a little tiny bit of a low dose of a pain medicine. We're not talking massive amounts. We're talking little tiny amounts over time. That is often a really nice way of entering into that pain discussion. Alrighty. Oh, Patricia is a 90-year-old from Missouri. It's very nice to see you, Patricia. My mother is 90. My dad is 95, and I care for them. They are outside that door right now. Alrighty. Whoops, where'd my mouse go? Hold on. Oh, here it is. Sorry, I have two different mice for my computer. Hello, Ruthie. Hello, Deb. Amy on YouTube says she woke up uncontrollably twice with her head shaking. Can lack of sleep cause it? I don't know, hun. I have a tremor myself. You can often see it in my videos because my head will go like this very subtly. Sometimes it's like that. And that happens when my neck muscles get very, very tight from working a lot. So I think that's something you got to talk to your doctor with. But at the same time, take a look at your neck muscles. Are you relaxed? Are they comfortable? Are they hard? Are they soft? Are they painful? Again, I'm not a sleep expert in any way, shape, or form. And so that's a really, really good question for your doctor. Also on YouTube, Sherry's asking, I've been in a flare for about 2 weeks. Up till now, I've been in remission. Don't know what to do. Please help. All right, so we're going into our flare protocol here, my friends. So the first thing you do when you have a flare is we got to figure out the type of flare you're having. So when is your pain the worst? Before you pee or after you're done peeing? Okay, if your pain is worse as your bladder fills with urine and is relieved by urination, that tells me you're having a bladder wall flare. If your pain is worse after you're done peeing, that tells me that it's probably a pelvic floor flare. So Sherry, if you could answer that question in your chat, that would be great. And we will take that up. In the meantime, we're going to come on over to Facebook. Hello, Ruthie. Hello, Deb. Hello, Jackie. How you guys? Amanda. Okay. Wow. Amanda had her third visit to the emergency room for a kidney infection and IC flares and blepharitis. The doctor didn't even hook you up to an IV, didn't help you with anything. I ended up leaving far worse. They never understand or care. So, Amanda, if you continue to have recurring bladder infections or recurring kidney infections, you are the perfect candidate for next generation urine testing. And if you can go to, I've got a little slide here. We started a little late today, guys, because we have massive wind here and we're under a big fire danger, and I couldn't connect for a while. The internet was down. So we'll hope it lasts up. All right, here it is. All right. So Amanda, with recurring kidney infections, recurring bladder infections, we have to ponder two things. You either have a drug-resistant infection or your body lacks the defenses that it needs to fight that infection. The way you find out if you've got a funky, very resistant bladder infection is with next generation DNA urine testing. You just go to bladderhealth.org, and patients in 25 states can order it directly. This is a perfect adjunct to traditional urine testing. Because in traditional urine testing, they use a little agar plate. They try to grow your bacteria out in your urine to see if anything grows. But now we know that form of testing is fairly limited. It will only grow out 1% of the potential bacteria in the bladder itself, because the bladder has good bacteria and bad bacteria. The urine testing, which will grow everything out, both good and bad, both bacterial and fungi, is next generation DNA urine testing. And so if I were you, this is what I would do, is I would come over here and check that out and maybe get that get your urine tested, and let's see if it finds something. Let's see if it finds that if you have a drug resistance gene in your urine, which would explain why you're getting recurring kidney infections. You know, if you have infection, that's not a flare, that's infection. Okay. And so, yes, you're going to be doing things to protect your bladder. You're not going to be doing cranberry. You're going to be following the IC diet. But ultimately, if you have a pathogenic infection, you have to treat it with antibiotics. All right, let's go back to YouTube. So Sherry is having a flare right now, and I asked her, when is your pain the worst, before you pee or after her pee? So here's what she's saying. After peeing, but it still burns afterwards, also with a lower abdominal achy pain. The lower achy pain seems to come and go. Rest helps. Feels like a bladder infection. All right. So Sherry, I'm going to challenge you here. I actually think you're having a pelvic floor flare. Because when muscles are working hard, they build up lactic acid in the muscle tissue. And what does that do? That causes your muscles to burn. You know, if you were going to go run around the block, your legs would start burning about halfway. Why? Because those muscles are working hard. Pelvic floor muscles work hard too. And when they do, they build up lactic acid and they start burning. And so that lower achy burning pain is in all likelihood probably a pelvic floor flare. Now, so what you would be doing now is you would be doing things that would help to calm and soothe those muscles. I would take a hot shower. I would use a heating pad. If you've got a muscle relaxant, you can try a little bit of a muscle relaxant like baclofen. Baclofen is a non-sedating muscle relaxant that can be taken during the day. And let's see if that helps. If you guys sign up for our newsletter on the IC Network website, you will get as our gift our flare management guide, and it has hour by hour rescue plans, right? So you can sign up for our free newsletter, and that will give you more tips on what you could do the first 30 minutes, the first hour, the first 2 hours, et cetera, et cetera. And my friends, I do have gifts as always. If you have not yet gotten our IC Awareness bracelet, even though IC Awareness Month is over, if you send me your mailing address, I will send you our IC Awareness Month bracelet, and I will send you our food card, our new diet card. Okay, foods to avoid. Foods that are usually bladder friendly. Of course, everybody can be, there are some people who are quite unique, but in the end, that is a very, very good guide. So where do you send your information? IC Network at mac.com. And let me write that down for you. See, you would think that I would actually have a slide for that, but no. You know, and for that matter, IC Network at mac.com. So send me your snail mail, your name and address, and I'd be happy to send you that. But you know what? Let's go whole hog here. I got other stuff. I always have books that have been damaged and or books that are we've discontinued for one reason or another. And and I will send these to you for free for the first person who emails me. Okay. So I have got a book called Sex Talk. This is for couples who are trying to restore their intimacy when you've been challenged by something like IC. Now let's see, I can't even get it out of there. Sex Talk. Uncensored exercises for exploring what really turns you on. If anybody would like this, the first person to email me at icnetwork@mac.com, I will send it to you, no charge. I also have a mitral valve prolapse survival guide. Same thing. First person who wants it emails me. I will send it to you for free. If you're struggling with your self-esteem, as we all have, I certainly did in my 20s tremendously, which led to a pretty significant bout of depression for a while. I have this fabulous book, The Self-Esteem Companion. And if you would like this, send me an email. First person to do it, you will get this book. If you're struggling with muscle tension in your body, look at this. I will send you Daily Relaxer. Relax your body, calm your mind, and refresh your spirit. Again, the first person to email me does it. It's not going to go to the same person, though. I have a second sex talk. So the first two people for sex talk will get it. Five ways to soothe yourself without food. I've got 2 of these. Anybody who wants these, email me and I will send it to you. I also have the highly sensitive person's companion. I've got 2, but I'm only going to send out 1 because I'm keeping 1 because I'm going to write a book on sensitivity. All right. So there you go. Some more freebies from the IC network. Last but not least, I do have 2, The Women's Guide to Thyroid Health. So if you want them, email me. All righty. All right, let's keep going with some of these questions. And again, my cushion on my chair is being funky. All right. All righty. Let's take some more questions here. Gina, you're welcome. I'm glad you got the bracelet. Julie says, for sleep, my doctor has me on melatonin, hydroxyzine, Lunesta, and Xanax. What are your thoughts on these? Other suggestions to help me with my sleep? Natural has not helped. Julie, I want you to come over to our website. We have a blog on sleep tips. Number one, the hydroxyzine is really good for helping you sleep, but a lot of patients make the mistake of taking it right before bed. Don't take it right before bed. Take it at dinner time. That way you've got a couple of hours for it to get into your system so that when it's time for you to sleep, you will be sleeping. So that would be one thing that I would be looking at. Make sure that you have a really good, and I'm terrible at this myself. I'm usually not to sleep until 2 a.m. every night, almost every night. But you got to have a good routine. Like you got to turn off all your electronics at 11, right? And for me, I know that every night before I go to bed, I take a hot shower because I want to really relax those muscles. When my IC was really bad, I found a relaxation tape that was fantastic. And it was from a company called Potentials Unlimited, and it was relaxation. And basically what I did is as I was trying to go to sleep, I would turn it on and then I would just start doing their exercises. I mean, it was this beautiful voice telling me to relax this, start at my head, work down. And I have to say that it was so good that after a week or so, all I had to do was hear the voice and I was out. And so I would also look at doing some sort of relaxation protocol. And we happen to have 2, actually 3 in our store, 1 for men, 2 for women. Guided Imagery to Enhance Healing by Beaumont Hospital, the #1 IC research center in the United States and really one of the best clinics in the United States. This is something that I would be doing before you go to bed. Literally, you've got your pajamas on, you're laying in bed, put the DVD on, work through it. And what you may find is that as you relax those, you do your deep breathing and follow what they're saying. I bet something like this is going to help you too. Alrighty. We used to sell the Potentials Unlimited tape. I mean, it was like, I couldn't believe that anytime I was having trouble sleeping, all I had to do was put it on. I was just out. My body was so trained to go to sleep to this guy's voice. It was amazing. I still have it somewhere. All right. Sarah asked, do you know if there's a link between pelvic congestion syndrome and IC, varicose veins from pregnancy, pushing on the bladder, or and the answer is no. I don't know of any connection between pelvic congestion syndrome and IC. However, your next question is a definite yes. She's wondering, is there a possible hormone issues from perimenopause causing IC? Absolutely. Absolutely. We call that the genitourinary syndrome of menopause. And here it is. I'm going to explain exactly why that happens. So here is a three-dimensional picture of the bladder wall, right? So at the top, you've got a layer of mucus. And if you can see this, the mucus is what keeps the constituents of urine from the more tender cells and the even more tender nerves and mast cell underneath this. Unfortunately, this layer of mucus is estrogen dependent. So when you're young, you have lots of estrogen, you got lots of mucus to protect you. When you're older, if you've had a hysterectomy, guess what? You have a lot less estrogen, therefore you have a lot less mucus. So as this slide shows, what happens is you've got areas which are basically denuded. There's no mucus there. So the irritants in urine, bam, hit your bladder wall and bam, cause those symptoms. You know, you got to remember that urine is waste. Urine is body waste. Urine contains ammonia and urea and the byproducts of all the chemicals that we've been exposed to. You know, I think, cigarette smoke, and something like 20,000 irritants from cigarette smoke end up in your urine. That's one reason why smoking is the number one cause of bladder cancer. So having a nice, thick, robust coating is really helpful to your bladder health, especially in 2018, where we've got so many irritants in our lives. You know, from the foods that we eat to the chemicals that we're exposed to, all that sort of stuff. Our bodies are being challenged on a daily basis by chemicals that we were not exposed to 500 years ago, 400 years ago, 50 years ago. And so again, if you're menopausal and you don't have a lot of mucus and you got a lot of irritants in your life, that absolutely is going to trigger bladder wall irritation, which we would put in IC subtype 2, bladder wall driven. The official diagnostic name for that is the genitourinary syndrome of menopause. And oftentimes the first sign of it is urethral irritation. That's what happened to me when I was like 52. It felt like there was a drop of urine stuck in my urethra that simply would not come out. And my IC self-help skills are really good, guys. I mean, I write the book on it. And yet for 3 months, I threw everything I knew at this urethral issue. And nothing worked. And so I finally called my urologist, put myself on his mercy. They did a sonogram. I was emptying my bladder, put me up in the stirrups, took one look, and he groaned. This is Dr. Mark Klein, who I'm forever grateful to. He was a fabulous urologist. He's retired now. So he took one look at me. So I am laying back, knees open. He goes, "Jill." I'm like, what? What did I do? And he goes, "Didn't you use the hormone cream I prescribed for you last year?" And I went, no, I didn't. Because in my brain, I'm 25 years old. I'm still 25 years old. It didn't even it was unfathomable that I would be at that age where I might need a hormone cream. And he goes, "Oh yeah, I wouldn't have prescribed it if I hadn't seen early signs of estrogen atrophy." And so they prescribed it for me again. They had me put a pea-sized drop at the entrance to my urethra, and within a week, the symptom was gone. I still do that today. If I forget to do it for about 10 days, symptom comes right back. So I know for me, estrogen, that little tiny bit of estrogen cream helps my body produce mucus. It protects my urethra. And he reported that the urethra in some patients is really that canary in a coal mine. That's often the first sign that you're struggling with a lack of estrogen in your mucous membranes. All righty. Yes, Manda, I do see comments, but I have to go slowly through them because there are so many of them, and I'm feeding through YouTube and Facebook at the same time. So Robin has an interesting issue. Robin is from Canada. Hello, Canada. I just want to say from the IC Network, we love Canada. I could go more, but I won't. Okay. One of the biggest issues is for urgency. If I do not go to the bathroom right away, then I can't get the urine to come out, which leads to pain and only a trickle every 10 minutes. So that, my friend, is pelvic floor tension. So what's happening is your bladder's hurting. You're holding it. The consequence of unresolved pain is guarding, a muscle guarding reflex. And so when your muscles get tight, guess what? You can't pee. And then you might slowly trickle, but ultimately you're going to have to wait until those muscles relax again. John asks, what are my thoughts on fascial restrictions causing burning and pain? Can the fascia cause pain, or is it more muscle related? You know, John, I don't think we really understand quite yet what the role the fascia plays in pelvic floor, other than that it is clearly playing a significant role. I know that I have fascial restrictions on the left side by my SI joint. And I know that I feel better when they work it out. I know that when I roll on a foam roller, it helps. You know, guys, you've got multiple structures in your muscles. You've got muscle tissue, but you've also got fascia. And fascia is connective tissue that connects muscles to bone and all that sort of stuff. And there's probably even a better definition for that than me. I'm not an expert in that. But what we're finding is that sometimes the fascia itself gets tight, dysfunctional, and inflamed. And so when they're doing physical therapy, they're not just working with muscles. They might be working with fascia. They might be rolling with fascia. And, you know, I thought I put it out here. One of the things that I use for my issue is a lacrosse ball. They sold it at my physical therapy clinic. And you just, on a wall, you just put it where it hurts and roll on it. And I got to tell you, it's remarkably painful when you've got messed up fascia, but this will break it up and loosen it up. And so you might want to try rolling on a tennis ball at the same time. All right. Sherry, you're only 43. So Sherry's the one who was asking about the estrogen. Perimenopause starts in your 40s. It started in my 40s for me. And so, you know, and again, part of it's genetic too. Maybe your mom, maybe the women in your family start entering that a little bit earlier. Maybe you're, I don't know if you've had a hysterectomy or anything else like that, but it would be completely typical for somebody in their early to mid 40s to start seeing that. Okay. Early signs of perimenopause: anxiety for no reason. Like for me, I was literally out for lunch with my sister and I just wanted to run out of the room. I don't know why. Well, I do know why. It was a hormone flux. Feeling angry for no reason, like you want to punch somebody. You ask yourself, why am I angry? And you have no answer. There's no reason why you're angry. And again, that's a hormone swing. And so I bet if you Googled perimenopause symptoms, you might start seeing you're just at the part of that. And we all go through it. Julianne says, is there a link between polycystic ovarian syndrome and IC? I think there is, because I have polycystic ovarian syndrome. I mean, I've had dozens of ovarian cysts. We've got the endometriosis link and we got the polycystic ovarian link. And women are one or the other. We don't know why that happens. We don't know why some patients get a lot of ovarian cysts, but I think there's a link. I just think that we have not figured that part out yet. Clearly, it's a hormone issue. It might be an environmental hormone issue like endometriosis. We know that there are a lot of chemicals out there that are hormone mimickers. Dioxin has been proven to cause estrogen atrophy. You guys, I smell something burning. Hold on. I'll be right back. Hold on. Hey, a 90-year-old, 95-year-old, let me just go make sure. All right. That was a well done pancake. Everything is fine. The stove is off. Got to be on top of that. All righty. Sherry says, how do you make the burning stop? Physical therapy? No, you can make the burning stop by relaxing the muscle. So if you've got tight pelvic floor muscles, number one, you need to go have a pelvic floor assessment. Let's confirm that. We're guessing right now. We want to confirm that. A physical therapist should be able to not only prove that you've got tight muscles, but they can be specific and tell you which muscle group it is. And then based upon that muscle group, they will give you exercises and stretches that will relax those muscles. So, but what you should also do is you should invest in one of these books, Ending Female Pelvic Pain by Isa Herrera, Ending Male Pelvic Pain by Isa Herrera. Also, just to throw this out here, she also has a new book, Ending Pain in Pregnancy. Not that, I mean, that's not relevant to us, but I just throw that out there. Or Heal Pelvic Pain by Amy Stein. You need to invest in one of these books so that you know the right exercises to do. Okay, because every muscle works in a different way. You know, with a glute, with tight glute tension, you would do downward dog. But if you've got tight piriformis muscles, downward dog does not work. All righty. Lee says she is on her 4th day of Sister Renew, and it has given you some relief from symptoms. Not full relief, but I was able to stop taking Urel. Yeah, awesome. I love hearing that. You know, guys, it's easy to discard supplements, but you got to understand the American Urology Association encourages the use of supplements before traditional medications because they have less side effects. And they're also remarkably inexpensive compared to, say, $2,000 for Elmeron. And so there are the supplements that are commonly used by IC patients are Cysto Renew. This was created by Dr. Gio Espinosa at New York University, or Cysto Protec. This was created by Dr. Theo Harides, a federally funded ICU researcher at Tufts University, or Desert Harvest Aloe. Desert Harvest Aloe is the only company that actually did a coveted double-blind placebo-controlled study to prove that their product had the potential of reducing IC symptoms. And of course, Preleaf. Preleaf does not act on your bladder. It reduces the acid level in your urine, so your urine isn't hurting so much. So, Lee, I'm really glad to hear that. You know, when I take a supplement, and I've never taken Cysto Renew because my bladder's pretty good right now. When I was taking Cysto Protec, I only took one a day. I couldn't take more than that because it gave me a loose bowel. So when I took it, I just took one a day. It felt like warm cotton candy in my bladder. It was pretty cool. I mean, that was how it felt to me. JJ says, do some women get a hysterectomy when they actually had IC? Absolutely. In fact, Diane Manhattan, the woman who helped me start the IC network 25 years ago, is one of those. She had a completely inappropriate hysterectomy when she was 23, 24. We had a very famous case of a woman who won a couple $1 million from the military, from the VA. So she had IC. She went into the hospital. She had a hydrodistension first. The urologist confirmed that she had IC. The gynecologist went into the OR next, did not look at his notes, and did a completely inappropriate hysterectomy on her. And she won a couple $1 million because it was such an egregious violation of her body. And it was so sloppy not to have talked with the urologist and read his surgical notes before just going in and doing it. Okay, so we see that all the time. We also see appendectomies, completely unnecessary appendectomies that happened to a woman in my support group, Linda, who had terrible pain, goes to the emergency room. The emergency room here in Santa Rosa was our community hospital at the time. And she kept saying, it's IC, it's IC. And they go, no, it's an appendectomy. It's your appendix, your appendix. And so they convinced her. She had her appendix out. And when she woke up, they went, we're so sorry. Your appendix was healthy. Yep. Yes, yes, yes. That's why, again, we do these support group meetings, because I really need you to be so knowledgeable and so informed that you cannot let a doctor talk you over that and talk you into doing a completely unnecessary surgery. Okay. You got to know your facts. You got to have your ducks in a row, my friends. And again, JJ, only to have the pain continue afterwards. Exactly. You know, it was Dr. Lowell Parsons, the doctor who invented Elmeron, invented something even more important than Elmeron. It's called the PUF questionnaire. I think that stands for pelvic urinary frequency survey. And it's a little 5-minute survey that gynecologists can give to patients to differentiate between reproductive pain and bladder pain. And that PUF questionnaire is outstandingly good. And we have a link to it on our website. So that's another way that somebody can tell the difference between bladder pain and uterine pain or vaginal pain. Michelle says, doctors don't care. I never asked for pain meds. They don't work anyway. Michelle, I'm going to agree with you. At the local level, there are many urologists who really are not interested in IC. They don't provide good care for IC. They're chop shops, for lack of a better term. They do prostate stuff. They do TURPs. They do surgery. And a lot of doctors, remember, doctors love the challenge of surgery. And there's no surgery. It's rare that surgery is ever done on an IC patient. So it's important you understand that there are 3 levels of care. You've got your local doctors, who most of the time really aren't very good for a complex patient like you. Then you've got your regional doctors. So your regional doctor would be a urologist at a university somewhere near you. So like for me, I'm in Sonoma County. I would go to UC. I was sent to UC San Francisco or to Stanford. And the regional doctors are going to be much more accomplished at understanding and finessing the bladder pain patient, because they're sent all the bladder pain patients. They have, instead of treating 5 IC patients, they may have treated 2,000 IC patients. So the odds are their skill set's much better. But even then, sometimes their skill set's pretty limited. And that's when you go to a national doctor, because honestly, you deserve the best care ever. And if you're not getting satisfaction at the local or the regional level, then think about going to a national doctor, asking for that referral to a national doctor. There are 5 national doctors that I think are the most recognized in the United States. So you got Rob Moldwin in New York, out on Long Island. You've got Robert Evans at Wake Forest University. You've got Ken Peters in Royal Oak, Michigan at Beaumont Health. You've got Chris Payne at Vista Urology in San Jose, California. And you've got Phil Hanno at Stanford. Those really are the top 5. And so that's where I think you deserve to go, because you need to understand your subtype more. You know, if bladder treatments aren't working for you, the American Urology Association very clearly says if a patient is not responding to treatment, we need to revisit the diagnosis. Maybe we missed it. Maybe they missed it. Maybe your problems aren't your bladder wall. Maybe your problems are your pelvic floor. Or maybe you've got Hunner's lesions that were never treated correctly, that once treated may make your pain go away. So I don't give up. I don't want you to give up. I want you to remember that you deserve compassionate care. And if the doctor you're seeing is not giving you compassionate care, it's okay to move on. Okay. And move up the chain. I've got patients in California who fly to North Carolina to see Dr. Evans. Even if you can just go once, so that they can do a proper diagnostic workup for you. That's really not a bad thing. You can bring them their medical records, and the odds are you will get more information in that hour with that national specialist than you would have gotten years from a local doctor. Okay. Rita says, does chiropractic care help with IC? Well, again, remember we've got subtypes of IC. So we've got 5 subtypes of ICs. We got Hunner's lesions, bladder injury, pelvic injury, pudendal neuralgia, and central sensitization. So will chiropractic help Hunner's lesions? Absolutely not. Will chiropractic help a bladder wall injury? Absolutely not. Will chiropractic help a muscle issue? Maybe. If it's due to some sort of bony issue, your SI joint out or whatever, it might help in that circumstance. Will it help with pudendal neuralgia? Maybe, because pudendal neuralgia is often from tight muscles, which can happen if your joints are out of alignment. But it's certainly not going to help with central sensitization. So you have to understand your subtype here. Michelle says she's always in pain. Michelle, I would love for you to call me next week and let's see if we can figure out what's causing your pain, so that we can focus better on what might help reduce that pain. And you can call me at 1-800-928-7496. 1-800-928-7496. All right. Sometimes I've done chiropractic just a couple of times for my SI joint. I found it very violent and very aggressive. And I would never have done it when I was in terrible pain. I mean, it didn't hurt me, but did it help me? Not really, no. Manda says, you have allergies to amoxicillin and Bactrim, so you're always on Macrobid or Cipro and your body has become resistant. Well, hun, I want to clarify that a little bit more. If you have an allergy to amoxicillin or Bactrim, then what that means is that when you take that medicine, it makes it hard for you to breathe. You're having a real allergic reaction where your throat might swell, you might break out in hives, whatever. Whenever you have infection, the most important part of that test is antibiotic sensitivity testing. They need to tell you very clearly and very specifically what antibiotic will not work versus what antibiotic will work. And Cipro, the FDA issued an alert for Cipro 2 years ago. Cipro is no longer suggested for routine bladder infections because it comes with some pretty serious risks now. Aortic aneurysm is one. So they don't want patients on Cipro all the time. Cipro should only be used if there is nothing else that is available that will work, okay? And if you Google FDA Cipro warning, you will find that warning. But again, next generation urine testing is perfect in this scenario because it will reveal any and all antibiotic resistance genes, and it will help you and your doctor pick antibiotics more correctly, because clearly what you're doing is not working because they keep coming back over and over again. Bladderhealth.org. And remember too, if you're of a certain age and you don't have estrogen, therefore you don't have a lot of mucus, they will often also give you an estrogen cream to use vaginally, because that will not only build defenses in the vagina, but also some defenses in the bladder with respect to a little bit more mucus. In the class that I took on complex urinary tract infections years ago from the National Institutes of Health, and it was taught by Dr. Anthony Schaefer. What he said is, we never, ever, ever diagnose a postmenopausal woman or a perimenopausal woman with recurring infections as a simple infection. It is always diagnosed as a complex infection. And what they found in their research is that about 24 hours before that bacteria arrived in the bladder, it was in the vagina. And so that then had them ask the question, well, what happened to vaginal defenses? Why isn't the vagina capable of defending itself? And the answer, right, comes right back down to the loss of estrogen and estrogen atrophy and not having good mucus. So generally, anytime a woman at that age gets recurring infections, they will also give you an estrogen cream to use vaginally, as long as you don't have a history of estrogen-driven cancer. Aaron says, would a tight pelvic floor cause this pulling sensation? Oh my God, yes. Holy moly, yes. I know this because I went through 10 months of a pulling sensation after my hysterectomy last year. Brutal. It's like there's a fist up my vagina, just grabbing onto my viscera and pulling it down. I'd never experienced anything like that before, and it was annoying. That my doctor later confirmed that that was a levator ani spasm, a spasm of the levator muscles. Hi, Lark. Thank you. Thank you very much for your kind words. I appreciate that. Sherry says she was diagnosed in 2008. You don't really know your subtype. And we have a video on our website called The 5 Subtypes of IC. I want you to go watch it. That'll help you. You'll probably be able to figure it out on your own. You won't need a doctor to do it for you. Julie asked, what are the advantages of taking Cysto Renew versus Cysto Protect? It's all about methods of action. So Cysto Protect is an old formula, but it is the beloved favorite formula. It has 2 methods of action. It has quercetin for an antihistaminic effect and chondroitin and hyaluronate for a bladder coating effect. So when Dr. Theo released Cysto Protect 15 years ago, it very quickly became the top supplement. And we had been waiting for Dr. Theo for the last decade to create his next generation formula, but he's moved on. He's doing other things now. And so a new doctor, Dr. Gio Espinosa at New York University, he's a director of integrative urology. He created the next generation formula called Cysto Renew. Cysto Renew has 4 methods of action. So it's got the same 2 as Cysto Protect. It's got quercetin for an antihistaminic effect. It's got chondroitin for a bladder coating effect. But it also has a little bit of aloe in it for the soothing effect of the aloe and a little bit of lemon balm. Now, this is not citrus lemon. This is a mint with a lemony scent. And it is known for its ability to calm nerves. And what have we been focusing a lot on in IC in the last 5 or 10 years is how do we calm the nerves down in the bladder? And so the addition of lemon balm to this was, I think, particularly genius. And so Cysto Renew right now is the top supplement because it has 4 methods of action. And this is generally where people start. The only issue with this is it does have aloe in it. And if you are sensitive to aloe, if aloe gives you loose bowel, then you're going to go to Cysto Protect. If you have shellfish sensitivities, you won't be able to do either one of those. You'll have to instead try Cysta MD or Cysta Q. Lark uses valerian root to relax her muscles. Awesome. I didn't remember that. I appreciate you pointing that out. Allison says her IC kills her during her cycle. IC is well known to flare when estrogen levels are low. Allison asks, can IC hurt on the outside? We actually call vulvodynia IC on the outside. But really what it is an inflammation of the nerves underneath the mucus. And so does a IC subtype 2 bladder wall cause vulvar pain? No. Can tight pelvic floor muscles cause vulvar pain? Yes, because it can deprive blood flow. Can IC subtype 5 central sensitization cause vulvar pain? Oh, hell yes. Yeah. So again, it gets back down to those subtypes, and ultimately you've got to look at your age and your loss of estrogen. That's a #1 reason why that's going to happen. Though I had vulvodynia in high school for many years. And that was just nerves, redheaded nerves being super sensitive. Jenna says, does anyone have a black pepper flare Black pepper on food. In a modest amount, it usually doesn't, but for some people, yeah, it can be. Lee said your IC was worse during your period, so you stop your periods with birth control. Yeah, that makes sense. I mean, I personally think that as we ponder those 5 subtypes, there is a subtype in bladder wall that is a weird hormone dysfunction that we have yet to really understand. But I've certainly worked with patients whose bladder was out of control until they got their hormones stabilized in some way. You just have to understand that there are consequences to doing that. A consequence of doing that might be that your vulva gets a little bit drier because you just don't quite have as much estrogen. I'm not saying it's a bad thing, but I'm just, there's always trade-offs. Debbie says, I have constant pain of level 4 in my low pelvic area. Walking makes it worse. Urinating makes it worse. Can't walk straight up. I walk bent over. Anytime walking triggers pain, we're looking at muscles. Anytime movement triggers pain, we are looking at muscles. And so I'm going to say that your physical therapist might not have been trained properly to not get you through that. But you do say something in here that I think is particularly interesting, and that is urinating makes it worse, that you can't walk straight up. So you may be having bladder spasms. Now, a bladder spasm occurs as the last drops of urine come out. And so, your bladder is a hollow organ, right? And it gets bigger as it fills up. And then when you pee, it gets smaller and smaller and smaller and smaller and smaller. And then eventually the walls might touch. And it's the moment the walls touch that for some people, this violent spasm occurs. I've had it a couple of times myself with an untreated infection that I thought was a flare that turned out to be an infection. And it's a violent spasm. Bladder is composed of smooth muscle. Pelvic floor is composed of striated muscle. They're different types of muscles. Generally, when you're going through bladder spasms, that to me is the quintessential way for your bladder to tell you that it is severely injured and severely irritated. And again, we would look at infection, or if you were pouring acid in your bladder every day, drinking coffee every day, cranberry juice, whatever, that would create an environment where your bladder is just kind of screaming. And that spasm, I think, is a perfect scream for the bladder to get your attention. The good news is that there are antispasmodics like Ditropan that can turn that spasm off in 20 minutes. And so if you're having bladder spasms, you definitely need to talk with your urologist about it and ask for an antispasmodic. The thing with an antispasmodic is if you take it every day, after about 3 weeks, it's so good at deadening those muscles that it's kind of hard to pee. So you tend to use an antispasmodic on an as-needed basis. So again, Ditropan would be something I think that would be worth talking with your doctor about to see if they can take that care of, because when you say urinating makes it worse and you can't walk straight up, you're bent over, that's classic bladder spasm, because I have had that myself. Okay. So tomorrow I want you to call your doctor and say, hey, you think you're having bladder spasms, and see if they'll give you something like Ditropan to try. Okay. But talk with your doctor about it. Allison is asking, does anyone self-cath? Allison, quite a few people do self-cath. It's an excellent skill to have, so that if you ever are in urinary retention and or you can't pee for one reason or another, being able to whip out that catheter and empty your bladder is a brilliant thing to be able to do. So I commend you for having that skill. And people, if any doctor says, hey, you should learn how to self-cath, do it. It's a great skill to have, and it's really easy as long as you're willing to get a mirror and look at your body. It's amazing the number of people who don't know which hole is what in their crotch. Sarah says, would estrogen cream reach the wall of the bladder to replace the mucous membrane? It doesn't replace the mucous membrane. What it does is give the body a tool that it needs to build more mucus. And the answer is yes. Yes. When you put it in the vagina, they believe that it does cross over to the bladder to help the bladder. Aaron says, why does my bladder always feel full? And also, not to be weird or anything, but it's really hard for me to pass gas. Okay. So Aaron, you probably have very, very tight pelvic floor muscles, which is why it's hard for you to pass the gas. You know, the pelvic floor is the only major muscle group that has holes going through it, right? Because you've got urine going through your urethra, and you've got a vagina if you're a woman, or men and women have rectums, right? And so here's your pelvic floor, and right here is maybe where those are. Well, if this is all tight and crunched down, guess what? It's hard to let stuff out, and it's hard to let stuff in, which is why peeing is difficult, pooping is difficult, and having sex is difficult. Imagine trying to shove a penis up this tight muscle. Doesn't work. It hurts. So learning to relax those muscles and getting the therapy you might need to relax those muscles could be really helpful with that, because that actually could play the foundational role in your irritable bowel. So that's worth checking out. But also, why does your bladder always feel full? And if you're wondering what I'm drinking, and I don't have a spoon, so I haven't spooned it up, I am drinking my favorite bladder-friendly tea, which is Harney & Sons Pumpkin Spice Tea. If you have a Barnes & Noble near you, they always carry it during the holiday season. We have it in the IC Network store too. It's a rooibos-based tea. And it has rooibos with some pumpkin and a few other spices. It's never flared me. Got rooibos, natural pumpkin flavor, a little bit of cinnamon, a little bit of clove, a little bit of nutmeg. But it's very, very mild, very, very gentle. And again, I always dilute it with a creamer. All righty. So why does your bladder always feel full? So let's look at this. So we've got your normal mucosal barrier. We've got your urothelium, which are the cells lining your bladder. And immediately underneath that, we have nerves. The bladder has two primary nerve groups. It's got the alpha afferent nerves, which control frequency and urgency. And it has the C fiber nerves, which control pain. The alpha afferent nerves are deliberately easy to turn on, because these are the nerves that tell you when you need to pee. The C fiber nerves are hard to turn on. It takes some sort of traumatic event to turn on the pain nerves in the bladder. So generally, anytime you have a bladder insult, the first symptom you're going to feel is frequency, urgency. It's the first symptom to appear, and it's the last symptom to go away. Now, another thing that happens is, that the nerves, the alpha afferent nerves are really, really provoked if you get what we call a false sense of fullness, where even if your bladder is empty, you feel full. So let me describe a flare, and let's see if you can relate to this, okay? So you go to bed. So you go to bed at 10 o'clock, but you've peed. You peed, and you haven't had a glass of water in 2 hours, right? So you peed before you go to bed. You wake up an hour later, your bladder feels very full. You go to the bathroom, you pee out a quarter a cup of urine. You go back to bed. 30 minutes later, you wake up, your bladder feels very full. You go back to the bathroom, you pee out a teaspoon. You go back to bed. 15 minutes later, you wake up, your bladder feels very full. You go to the bathroom, you push and push, and you get a drop. Because at that point in time, your bladder really is genuinely empty. And for the rest of that night, you're stuck in this false sense of fullness. And some patients make the mistake of going into the bathroom and pushing and pushing and pushing and pushing, because they're not understanding that their bladder really is empty of urine. There's really very little there. Rather, it is a sign of nerves in the bladder wall that are super, super irritated. So again, we're going to look at something in your daily life that is provoking those nerves over and over and over again. A good example is, do you take a multivitamin? Multivitamins, because they contain ascorbic acid as well as B6, are really well known to be a daily irritant to the bladder. Are you drinking water through a Brita water filter? Again, Brita filters are so freaking good. They take all the minerals out. When you take all the minerals out, you end up with acidic water. So you could be drinking acid water all day. Or are you one of those stubborn people where you're still drinking a cup of coffee a day, or a green tea or a black tea, or just something you're just cheating every now and then, as we have all been known to do? That constant fullness is kind of one step below a bladder spasm. That, to me, is your bladder asking for your help and notifying you that it's irritated. And we've got to figure out why it's irritated. Hello, Kareem from Belgium. Very, very nice to meet you. Jennifer says, do you recommend a TENS unit to help with bladder pain? Sure. I wore a TENS unit for years. I actually put it on my inner thigh. The theory behind a TENS unit is something called spinal gate theory. Okay, so, our body has, I don't even remember, like 10,000 pain receptors. And if they were all firing at once, we would be overwhelmed. But instead, what happens is your spinal cord kind of acts as a gate, and it only lets the most important pain message through to your brain. So if you stepped on a nail on Friday, believe me, that's up in your brain, and your brain is telling you to move your foot, and you're hurting badly. But let's say 3 days later, you fall and you hurt your tailbone. That spine is only going to let the most urgent pain message through. You're not even going to feel your foot during the second accident, and you probably aren't going to feel it for some time. So the most intense pain goes up the spinal cord to the brain. And there's a really good book that I read called Pain, the Gift That No One Wants. It's an excellent book. And it was written by a doctor who was studying leprosy in India. And one of the things, and he's the guy who basically invented the TENS unit. So here he is in India going to these leper clinics. And leprosy is a bacterial disease, for those of you who don't know. And it causes profound tissue damage. I mean, fingers turn black and fall off, and it's terrible. It's a terrible bacterial disease. So he would go to these leper clinics, and what he would find is these patients would be doing this. And at the clinic, all the clinics he was going at, they would be doing it. And he finally asked the doctors, why are they doing that? And what they were doing is they were triggering that spinal gate to stop the leprosy pain. And this becomes the dominant pain that your brain pays attention to. And that's what a TENS unit does, kind of, sort of. What a TENS unit does is it diverts your brain to another source of pain. So I remember I had to fly to Europe to go speak on IC, and my pain was raging. And I had, it is like misdirection, Donna. Yeah. I was on the plane, and I had my TENS unit pad here and here. And I had it turned up, and I turned it up too much, and I actually kind of burned myself. But that was the theory that I understood with respect to how a TENS unit was developed and why a TENS unit was developed. In this book, in Ending Female Pain and Ending Male Pain, there is a section in here that talks about the different places that you can put your TENS unit pads. So here we go. Now, granted, you guys, you have to understand, when I was using a TENS unit, it was 25 years ago. Okay, we've learned a lot about it since then. So I would never even thought back then putting it in these locations, nor did my doctor. My doctors all said, put it on your leg. But again, Isa Herrera, she gives examples. So here's one that can go up your spinal cord. Low back, butt cheeks. This is low back, but also right at the base of the butt cheeks, which really makes sense to me because it's right there that I often have a vibration pudendal nerve entrapment is like right at the base of the butt cheek. So putting it there kind of makes sense to me. Lower belly, right? So again, if you're thinking about using a TENS unit, get this book because it'll help you. It'll give you lots of different things that you can do with this. Hello, Chris. Hello, Diana. Allison says, is IC genetic? IC subtype 5 can be genetic. It is genetic in my family. It goes back 3 generations in my family. My sister, my mother, my aunt, my cousin, my grandmother. But again, it's all about your subtype. So are Hunter's lesions genetic? No. Is bladder wall injury genetic? No. Is pelvic floor? No. Is pudendal neuralgia? No. Is IC subtype 5 central sensitization potentially genetic? Yes. That is a small population of the IC community, and that's kind of where we look. Kathy says her doctor did a cystoscope and perforated your bladder. Well, his skills were not very good. I'm so sorry about that. Jenna says, a cystoscopy was done decades ago to diagnose IC. New urologist wants to do one. Would that be necessary since I already have a diagnosis? So the way the American Urology Association guidelines are written is a hydrodistension with cystoscopy is no longer considered the gold standard for diagnosis. Okay, why? Because we now know a hydrodistension with cystoscopy can cause a false positive, that when you stretch the bladder, blood vessels bleed anyway, even in normal people. So in the AUA guidelines, a hydrodistension with cystoscopy is only done if the diagnosis is in doubt. If the doctor isn't sure, if the doctor thinks that you might have Hunter's lesions, something like that, or the doctor wants to do a biopsy, that's when a hydrodistension is necessary. But a cystoscopy is what I call a looky-loo. There's no hydrodistension. It's done in the office. It's a 5-minute procedure. You basically lay on the table. The doctor numbs your urethra with lidocaine, sticks a cystoscope in, looks around for a couple seconds, pulls it out. You're done. 5 minutes, you're done. I call that a looky-loo. It's a very quick, brief examination of the bladder wall. And if my doctor wanted to do one today, I would let him. Because I don't like guessing. I don't like guessing. If you're in pain, if I'm in pain, I want somebody to look. And I've told the story in some of these earlier things. I had a very interesting case earlier this year of a woman who had suffered with IC symptoms for years. And she was afraid to have any testing done. And finally, after years, she just got to the point where she was so desperate. It's like, okay, you can look. You know what they found was a giant kidney stone floating in her urethra that was really sharp. It was a calcium oxalate kidney stone. And it was so big, it would not pass through the urethra. So imagine she had the sharp crystal floating in her bladder wall for years, cutting her bladder wall. As soon as they broke it up and got it out, her bladder healed, she's fine. So that's yet another reason why there's an important opportunity and information to be had when you allow a doctor to take a look with a cystoscopy. Now, if it's a hydrodistension, that's another story. It needs to be a low pressure, short duration, not a high pressure. I can talk about that a bit more if you would like. Jenny has pain both external and internal. All right. Lee, Allison, your sister and you both have IC, but we do have different subtypes. Okay. Jenny asks, she has an ovarian cyst that needs to be removed. Will this cause flare-ups or any pain related to IC? It shouldn't, except you're going to have surgery, and that's going to involve an incision and potentially moving some muscles around. For the short term, you can expect some neuroinflammation in that area. Your muscles might be tight afterwards, but that should heal over time. I mean, I had a hysterectomy last year, which is much worse than what you're doing. And did it affect my bladder? No. Did it affect my pelvic floor? Absolutely. Absolutely. Somebody's car alarm is going off somewhere. Nancy says, I've had IC for 4 years now. I also have IBS and have started having, here, hold on, let me shut the window. All right. I've had IC for about 4 years now. I also have IBS, started having symptoms like yeast infection and burning. The doctor tested, there's no infection. Okay, hold on. This is a really good question. So let me just read this one more time. So Nancy said, so again, Nancy has IBS, but now she started having symptoms like yeast infection and burning. The doctor tested, there's no infection, but the burning and feeling swollen inside won't go away. Is this IC related? So number one, Nancy, I would want to know, did they test for Candida? But number two, what is the quality and health of your skin? Because really, some of those symptoms we're going to associate more potentially with estrogen atrophy. When you're having, so I mean, I certainly went through a period where I felt like I had a yeast infection every day. And it was, and that was from like the age of 18 to the age of 23, 24. It was wicked vulvodynia. My mother, who's 90, has wicked vulvodynia now. So again, vulvodynia means that the nerves under the skin are speaking. They have been irritated in some way. So the question is why? They can be irritated by chemical irritant. So one of the first things that we would have you do is to eliminate any chemical exposure. You shouldn't be using any douches. No liquid soaps. Be careful with your spermicides. The only soap you should be using is a plain unscented Dove bar, not the liquid soap. Look at your laundry detergent. You don't want to use a big mass market scented product, that's for sure. But even Tide unscented irritates me. I mean, within 5 minutes, I'll have urethral burning. So I use a natural laundry detergent called Planet. And that's been helpful. You can't use any fabric softener. You can't use any laundry sheets down there. Do you wear mini pads? You know, a lot of patients, myself included, wear mini pads. And I wear a mini pad because every now and then, if I get startled, I might leak a little tiny bit. Never a lot, but hello, I feel more secure. Okay, but that said, some mini pads are just filled with caustic chemicals. And when they get wet, those chemicals off-gas right up into your tissue right there. I know that the new Always pads did that for me. I go with the old Always pads, not the new ones, not the scented ones, anything like that. So I would also be looking at chemical exposure there. And honestly, again, you're an interesting candidate for next generation urine testing because this will identify fungal infections, not just bladder infections, but fungal infections. Okay, but if you want to call me next week, I'd be more than happy to talk with you a little bit further, see if we can finesse that a little bit further. Brittany says, you've been having rectal spasms. You saw Dr. Evans last week, and he is sending me to a Go doctor. Don't know what that is. He did a hysterectomy in January. It was 5-hour surgery, removing a ton of adhesions. These spasms are flaring my pelvic floor and bladder. Is this common? Hun, I had rectal spasms for 10 months after my surgery. And if you had your hysterectomy in January and it's only 10 months later, you know, you're probably going through what I went through. I'm 14 months, 15 months post my hysterectomy, and I still get them every now and then. I had a couple last week, a couple days ago. Very frustrating, very, very frustrating. So you could just be having some levator ani spasms from the hysterectomy, and been there, my friend. If I could give you a hug, I would, because I know how frustrating it is. And ultimately, pelvic floor physical therapy was what turned it off for me. When I finally I had my surgery in May. In December, I was at my doctor crying, talking about this pulling sensation and these rectal spasms. He took one look and he goes, oh my God, I can see your levator spasming. You are having involuntary levator spasms. And I was like, okay, fix it. What can we do to make it go away? You know, I was walking around. I'll give you an impression of how I was walking around. This is how I was walking. For 10 months after that surgery. I mean, when it was hitting, it was just hard. It was hard. And I'm going to tell you right now that pelvic floor physical therapy worked it. But it was painful at first. It took time, you know, to work through that because my muscles were really messed up from that surgery. So I would hazard to guess that you might be in that same position that I was in. Sarah asks, what is the best treatment for a bladder wall injury issue? My urologist just wants to do a hydrodistension or instills. I take aloe vera and probiotics and follow the IC diet. Well, you have to work your way up the chain, hun. You got to work your way up the 6-step protocol until you find what works for you. So it's in step number 1 of the AUA guidelines for IC. You got to drink plenty of water. Keep your urine nice and dilute. You know, if your urine is dark yellow, you're dehydrated. If your urine is clear, you're drinking way too much water. We want your urine to be a clear, pale yellow. Doing the supplements is good, but if you're just doing aloe, why don't you try the Cystro Protect or the Cystro Renew? That might be interesting. That would add more of a bladder coating effect, along with the quercetin, which would add an anti-inflammatory effect. That might be very interesting for you to try. And then in step 2 of the treatment protocol, we've got hydroxyzine, the antihistamine. That would be reasonable. You know, hydrodistension is in step 3. Well, let's exhaust step 2 first. Let's make sure you've tried everything in step 2 before you go to something that's much more invested. So these are the American Urology Association guidelines for IC. Step 1, water intake, diet modification, supplements, muscle relaxation, acupuncture. And, you know, and guys, I mean, I really got to tell you, you can't blow this off, especially if you're IC subtype 1, subtype 2. You cannot blow this off, and subtype 5. You'd be amazed the number of people who go all the way to step 4, step 5, and they don't do any of this. And I will tell you that the vast majority of patients get success with step 1 and step 2 and never need to go past that. So don't underestimate the importance of just modulating your water and playing with your diet and trying the supplements, okay? Let's see. Step 2, my friends, physical therapy, oral meds, bladder instills, and pain care. So Brittany, let's see. No, it wasn't Brittany. It was Sarah. I still think you need to have a pelvic floor assessment. Make sure that your pelvic floor is not tight, contributing to your bladder wall poor health. Oral meds are going to be a low-dose antihistamine, a low-dose antidepressant, and/or heparin lidocaine, and/or Elmeron, although we are having some issues with Elmeron right now with respect to eye damage, and pain care. Step 3 is cystoscopy with hydrodistension. Low pressure, short duration, guys. If you do agree to do a hydrodistension chair, man, you got to make sure he's not going to do a high pressure, long duration. He needs to be as gentle as he can possibly be to avoid traumatizing or injuring your bladder. Okay. And if you have Hunner's lesions, let's get those Hunner's lesions treated correctly with fulguration, steroid injection, and/or Liris, the medical device. I still do not have an update from the company Allergan about what's going on with Liris. Hunner's lesions require lesion-specific therapy, and when you treat them correctly, the pain goes away for many, if not most patients. Step number 4, neuromodulation, which is urgent PC, InterStim, and/or Botox. Step number 5 is cyclosporin. And step number 6 is rarely used. Step number 6 is surgery. Treatments that are no longer recommended: long-term antibiotics, BCG, RTX. BCG is Bacillus calmette-guerin, which is a bladder cancer treatment. Research studies prove that it did not help. And RTX is called racina ferritoxin. Research studies also prove that that did not help. We certainly are not going to do silver nitrate or chlorpactin. Those are the old bladder strippers that were used 20, 30 years ago, back when we thought every IC patient had a dysfunctional bladder wall. Their approach back then was to strip off the bladder wall completely with the hope that it will grow again healthy. We now know that's completely flawed reasoning and causes tremendous damage. So we're not going to do silver nitrate or chlorpactin. We're not going to do high pressure hydrodistension, and we're not going to do long-term steroids. Those are not recommended as treatments for IC. And if you have a doctor suggesting that you do them, then that is a doctor who's not aware of the AUA guidelines, and you should bring them to him. Ruth Ann says she's had 4 DMSO treatments and feel worse. Yeah. DMSO is really not popular anymore, even though it's still FDA approved. It has been displaced by rescue installations, heparin lidocaine installations, because those usually don't hurt, where DMSO can hurt. There's a place for DMSO, but it's certainly fallen out of favor quite a bit. I did 8 treatments of DMSO. It didn't help me. And I made a fundamental mistake with DMSO when I tried to drive home with it in my bladder, and I got stuck in a traffic jam, and I was bawling my eyes out because it hurt so bad. But for me, my DSO treatment was kind of a pivotal moment for me because I felt worse. I felt worse after doing DMSO. And I didn't understand, I mean, aside from the biology of it and the pharmacokinetics of it and the proposed way that it might help, what I knew as a patient for me is that I didn't feel better. I felt worse. And it kind of dawned on me that why would I do something that made me worse consistently every week? I wanted to focus my treatment on things that made me feel better. And that's why the rescue installations, diet, other things, supplements just made a lot more sense to me personally. This was way before the AUA guidelines came out. So, let your doctor know that you feel worse. Maybe they can adjust what's in it. Maybe they're using too high of a dosage. DMSO should be done in a DMSO cocktail. We know that the FDA-approved dosage of 50% DMSO has now been disproven in research studies that were presented as research at the American Urology Association 15 years ago. We know that a 50% dose of DMSO can cause irreversible muscle spasm. So there is a gentleman's agreement that DMSO, when done, is usually done as part of a cocktail with other ingredients, including heparin, including maybe a steroid, maybe an antibiotic. Ultimately, though, that reduces the dose of DMSO to about 25%, where it is found not to cause those muscle spasms. So that would be the other thing that I would be looking at is how are they giving it to you? If they're giving it to you straight DMSO, you know, that's really not done anymore. It's usually done as a cocktail. Chris Swain, how do we get the new next generation urine test if we're not in one of the approved states? You're in Georgia. You just have your doctor request it. When you order the kit, you get a registration form, and at the bottom of the registration form, they ask for a doctor's signature, and that's what you would send back potentially with your payment. Hello, Julie. Hello, Sheila. Hello, Jolene. Sheila just came in. Sheila is my best friend from high school, and she has been with me through every major IC event, and I am so grateful, so incredibly grateful for her caring and kindness towards me. Best friend ever. You know I mean that. Okay. Brittany, yes, I do think you're probably having the same post-op infections things that I have. Lark takes lemon balm capsules. Good. Very interesting. Hello, Liz from Ontario. Is it a good idea to take Cysta-Q and Cysta-Renew twice a day? Girl, you got to follow the manufacturer's recommendations. With Cysta-Renew, it is 4 capsules, usually 2 in the morning, 2 in the evening. This is Cysta MD, not Cysta-Q. Cysta MD is Cysta-Q with pre-leaf in it, basically. And this one is 1 tablet twice daily. So, you know, I come from a less is more perspective. I believe in starting in small quantities and working your way up. I don't believe that more is better. It's about finding the combination in which your body will thrive. And doing the Cysta-Q and the Cysta-Renew together, it doesn't really make sense, hon. I mean, I think it'd be much more interesting to do Cysta-Renew and Desert Harvest Aloe than the Cysta-Q. I mean, what the Cysta-Q is giving you is quercetin, and it doesn't say how much is in there, but you're also getting quercetin from the Cysta-Renew. Whereas if we're going for the bladder coating effect, maybe adding aloe might be a more strategic combination. Karen says, Pyridium saved her from one of the worst bladder spasms of her life. Yeah, that was good. Thank you for mentioning that. I forgot about that. Pyridium is the medication that turns your urine orange. You can buy it over the counter now. It is Azo pain relief tablets. Janice says she used to use Cystex Plus as I can't take Pyridium, but you now can't Cystex either. You know, there is an issue with Cystex. I thought I had it here. You know, whether it's Cystex or Azo, you're really not meant to use them on a daily basis. But there was a unique issue with Cystex, and I don't remember what it was off the top of my head, but I know I had a patient call and ream me out because I'd mentioned it, and she explained that I think she'd had kidney damage from it. So take a look at Cystex again. I don't remember the specifics. Hey, let me show you something cool though. Go Girl. You guys ever heard of Go Girl before? Go Girl is a female urinal. Let me show it to you if I can get it out. So here you are, desperate to pee, And this is one area where men have a great advantage over women, because with a man, you can very easily pee in a bottle, in the car, or in a plane cockpit, wherever. We women, unfortunately, have to drop our pants before we can pee. And even then, who knows what direction it's going to go, especially if your muscles are funky. Go Girl is a little adapter that you can use. You just put it between your legs, pee into it, and look at this. It has a nice funnel that you can then put into a bottle. So if you're ever looking for something like this, Go Girl allows women to urinate standing up. It's hygienic, portable, discreet, and usable. And there's another one. You know what? Hold on. You want to hear something? I'll show you something really good. Let me see if I can get it. Hold on. This one, God, I don't remember the name of this. This one, so it comes in a fabric bag. This actually works. I used it a couple of times. It's like a cough syrup spoon, where you just kind of slide it over where your urethra is, and you can literally, without dropping your pants, pee like a guy. And I don't remember the name of it. I got this like 20 years ago. And then we have Travel Johns. The Travel Johns are the best. I mean, you buy 3 for $3.99. They're white plastic bags with an applicator like this. They're filled with a little powder, so when you pee into it, it immediately solidifies. You throw it in any trash can. So seriously, guys, if you're ever worried about not being able to pee, buy some Travel Johns, put them in your car, and just knowing that they're there will take so much stress out of driving anywhere. You'd be surprised. I have a 3-pack in my car all the time. I've never had to use one, never in 25 years. But believe me, I want it there. All right, let's go back to your questions. Donna says she was stuck in traffic for hours and had it in your rescue kit. I got stuck in the Golden Gate Bridge for like 90 minutes. Oh, it was terrible. And that was, I don't know how I didn't pee my pants. I was just bawling my eyes out. That my IC pain was so bad back then. It was summer 1993 as I was going to UC San Francisco for a urology appointment. And that's when I got a pop-up tent and I got stuff so that not only could I do it, I could make some money doing it, because I figured I'd throw the pop-up tent next to my car and charge people $5 to pee in there. All right. Sherry says, what's the difference between hydroxyzine hydrochloride in the pill form versus Vistaril in the capsule form? So hydroxyzine is the scientific name for Atarax or Vistaril. And hydroxyzine comes in 2 distinct forms. Hydroxyzine hydrochloride, which is known as Atarax, versus hydroxyzine pamoate, which is known as Vistaril. The problem with hydroxyzine hydrochloride and Atarax is that it is often, especially the generic form, filled with different irritating fillers, where pamoate tends to be much purer. So I know in my case, I took 1 Atarax and I knew I could never take it again. It immediately made me feel very ill. So we switched to pamoate, and that was perfect. So what the books say is, for people who are more sensitive, try the pamoate first, try the Vistaril first. The only challenge is dosage. The lowest dose of Atarax is 10 milligrams, I think. The lowest dose of hydroxyzine is 25 milligrams, comes in a green capsule. So what my doctor had me do is just pry the capsule apart and took half one night, half the other night. Honey, Sherry, it's all about sensitivity. It's not about effectiveness. It's about sensitivity. If you're not having any issues with your Atarax, you're fine. If Atarax doesn't make you sick, you're fine. Use the Atarax. But for some of us who are more drug sensitive, we just don't tolerate the Atarax very well. Lark reminded me that Oxytrol antispasmodic bladder patches are now over the counter. You know, I totally forgot that. Lark. Thank you for, let me look at it real quick. I don't remember what the active ingredient is in that. Oh, it's oxybutynin. Perfect. Perfect. I got to start selling that in the IC Network store. God, I got to write that down. Yeah. So if you're having bladder spasms, go try an Oxytrol for women patch, and that might help too. Nancy says, what are the alternatives for Premarin? Premarin burns. Girl, Premarin is notorious for burning. There have been books written about the challenges with Premarin. Premarin comes from pregnant mare urine. It's that terrible industry where they keep draft horses pregnant, and they collect their urine to get the estrogen out of that. Then they kill the babies or give the babies to slaughter. And then they keep them pregnant over and over and over again. It's really a dark point in animal rights and animal care. One of the reasons why is that when you try to use estrogen from horse urine to make it safe for humans, they have to really chemically manipulate it. And Premarin is known for having a lot of extraneous fillers in it and other irritants in it that can cause that burning. I used Premarin once with my vulvodynia, and oh my God, I think I screamed afterwards. It was so bad. So your alternative is a preservative-free estrogen cream, and you can get that at a compounding pharmacy. So I get my estrogen cream from the Women's International Pharmacy. That's women'sinternational.com. And there's no extraneous chemicals in it. It's cheap. The tragedy of Premarin is that you see all these ads on TV for Premarin, right? You know, to get your sex back, makes things more comfortable. And a prescription for Premarin is hundreds of dollars. My prescription for preservative-free estrogen cream is $40 for a 3-month supply. So when you're buying Premarin, you're buying into the big pharma profit mechanism where they're charging more to pay for these big ads. You know, look at a local compounding pharmacy. Okay. I don't know. Oh, Amanda's asking, are those patches expensive? I personally don't know. Carrie, can IC give you sudden lower back pain? Yes, it certainly can. And many times that lower back pain is actually tight psoas muscles. IC normally doesn't cause kidney pain, but it can cause low back pain. And in many cases, that low back pain is from psoas muscles. Amanda says, what's a TENS unit? A TENS unit is a little box that produces electrical impulses, and you have a little patch that you put on your skin. You turn the box on. I have one here. Hold on. So here's a TENS unit that I bought for like $30. And you can see that it has a stimulator, and then it's got patches, and it's just where you put the patches that matter. And guys, seriously, TENS units should not hurt. More is not better with a TENS unit. A TENS unit is using a little electrical impulse to affect your nervous system. If you turn it too high, you run the potential of damaging your nervous system. So it should never hurt. Seriously, it should never hurt. You should feel it moving, but you should not feel pain. If you're feeling pain, it's on too high. AccuRelief. I think I bought it on Amazon. Aaron says, at some point in time, can we talk about Menta? You're going to have to refresh my memory. I don't remember what that is. Dawn, is TENS the same as neuromodulation? Yes, it's just non-invasive neuromodulation. I mean, the theory behind InterStim and Urgent PC is that that the nerves are dysfunctional, they're not functioning normally, and if you stimulate them correctly, they might behave normally again. Whereas the theory of a TENS unit is kind of to distract the brain from pain, but they're kind of the same thing. I mean, two different uses. It accomplishes both things. It can neuromodulate nerves, and it can also distract the brain. And so Aaron, call me and let's talk about it. We put something together on Menta, but you just have to refresh my memory here. April says she has urgency frequency. So far, the only thing that's worked for her is Elavil. She's gained about 20 pounds. Hello, we call that the Elavil 20. The problem with Elavil is it makes you crave more, and then you start snacking. And you gave up your regular coffee, can't afford physical therapy, would like to get off the Elavil. What can you do? Well, try the supplements, son. Try step 1. If you see me squirming, it's because my SI joint hurts. Hold on. Time to sit on the yoga ball. Oh, if only I were wearing tennis shoes. That would make it even easier. All right. Laura says, are there any studies on the long-term effect of the instills? I guess it's about how long-term is long-term. What are you looking for? Most of the instills that are improved probably have 2 to 3 to 4 year studies. But if you're asking for 10, 20, 30 year effects, the answer is probably going to be no. Sandy says she has medullary sponge kidneys and IC. You're talking about the lady with kidney stone. I pass stones all the time. Can passing stones be part of my IC? Absolutely. Because as you know, kidney stones are very, very painful. They're sharp. They have sharp edges. And as those are crossing across the bladder wall, that certainly can cut the bladder wall and irritate the bladder wall. Tabitha said she got her PCR back from Microgen. It showed E. coli and strep B. She's been put on Levaquin 3 days. I still don't feel better. The full report should come in the first of the week. The report said Levaquin should help both E. coli and strep. With E. coli, should I see my gastrointestinal doctor? No, you don't need to see your gastrointestinal doctor for that. It's about finding the right treatment for that. When you get your full test results from Microgen, it should show your any antibiotic resistance genes that are found there, and it should give you a much more complex. The PCR test is just the initial screening. It's that next level that you'll get this week that I think is going to be the most meaningful. I could show you mine. I don't know if I have them right here. Let's see. No, I don't have my Microgen test close by. Well, let's see what the next round says, okay? And really, you need to tell the doctor if you're feeling worse. If your urgency and lower cramps in front are awful, be in good contact with your doctor about that, okay? It's kind of a sign that whatever you have might not be responding to the Levaquin. Brittany says she's been a patient of Dr. Evans for 15 years. He's a wonderful guy. Victoria, thank you for your kind words. That's very, very sweet. Jolene, I'm an old silver nitrate patient. Awful, 40 plus years of IC. Yeah, remember those days, Jolene? Like, holy hell. What were they thinking that stripping the bladder? You know, I mean, that's why it's so important that we think of IC as injury or trauma. You know, in those days, they were really obsessed with the thought that IC might be some sort of funky infection. And of course, we now know that that infection usually isn't found except in chronic patients. But the theory back then was to just, you know, like put a, you know, I mean, it was like hitting an egg with a bulldozer. Throwing silver nitrate into the bladder and stripping the bladder wall off is pretty much cruel and unusual punishment. And it doesn't make sense now that we realize that there's injury or trauma. We don't want to make a wound bigger, and that's what it would do. Janice says azo test strips aren't accurate. You know, Janice, all you got to do, you're just going to have to try to see what you can get, hon. Go to Google and try some of the different brands. Laura says pre-leaf is very helpful. Good to hear. Guys, I just want to say with pre-leaf, I mean, listen, the pre-leaf is the most popular supplement out there. Don't think it's helping your bladder. It's not a quote unquote treatment for your bladder. All it's going to do is reduce acid level. And it's fabulous. It works for many, many patients, very, very few side effects. However, there are some patients who make the mistake of treating it like candy and they start eating a lot of it. And it is a calcium pill, and that calcium can come out in your blood, and it can also lead to the formation of kidney stones. So people who get calcium-based kidney stones cannot take something like pre-leaf. So just be moderate with it. Follow the instructions. More is not better, okay? Stacy went off the Elmeron and is trying the Sister Renew. Reasonable. Laura says Piridium makes her nauseous. Do you take pre-leaf with food? Yes. Kathy says, is D-mannose okay? If you struggle with recurring E. coli infections, D-mannose would be a very, very wise thing to take. Mannose is a sugar that the human body does not use. Therefore, it is immediately peed out and ends up in your urine. And there is a receptor on mannose that binds to E. coli. And so D-mannose can be a preventative for E. coli-based infections. It is not a treatment for an active infection. But if you're one of those people where you do get recurring E. coli infections, D-mannose would be something important to have in your toolkit. More is not better. I was talking with a patient this week who, oh God, I don't even remember. She's taking massive amounts of D-mannose and ended up, you know, having terrible side effects. And I asked her, why are you taking so much? And again, she was kind of obsessed with this more is better. And you just don't do that. Guys, we got to be moderate here. Thank you, Stacy. Soft surroundings. My favorite place for my sensitive skin is I now get soft clothes at the store. Soft surrounding. Christy said, what are the best home remedies? Because I have no insurance or income. Okay, so Christy, you're in step one. You're in step one of the AU treatment protocol. So you're going to be following the diet, trying the supplements, doing muscle relaxation when you can. That's pretty much what the American Urology Association says. And I would be careful. You know, there are some websites that, you know, say buy a book and cure your IC for $49. Please don't do that. That is a scam. That is a book that says salt causes IC. And of course, that author has written that exact same book and swapped the name out for Restless Legs and other, I think there were a couple of others. So please don't buy that book. There's some other websites that are promoting supplements like colostrum and things like that. I don't give them really any credence because we're, you know, with what we know now about kind of the subtyping, we want our supplements to accomplish specific purposes. Like a bladder wall coating versus an antihistamine, et cetera, et cetera. You can, like there are chiropractors who are selling supplements and patients will walk out with $300 or $400 worth of supplements only to have a flare afterwards. So when money is tight, then let's go to the supplements created by urologists for this. And I really don't believe in trying a lot of random things. You can start panicking, and you want to do this and you want to do that, and you talk to that person online who says this, and you go to that website on that says you can cure your IC and yada yada yada. Believe me, if I had the cure for this, you would be the first to know, because I have IC, and I would like that too. What we have to do is try to focus on facts and focus on method of action. And the products that have the method of action that makes the most sense, that is supported by other urologists in the country, are going to be the Cysto Protect, the Cysto Renew, the Desert Harvest Aloe. Christy, thank you for saying that, but I'm not a doctor, hun. I can't give medical advice, so please don't think of me as your only doctor. I am a support group leader, educator. I'm trying to give you the information so that you can make good decisions as you are waiting for the time when you will be able to get health care. I'm just reading a long comment here. From Victoria, I've been wondering throughout my research, seeing more clearly how an internal medicine doctor will be best to take over my plan of care, direct me to the best specialists, communicate with each of them. Boy, wouldn't we all love that? Wouldn't we love a primary care who was actively networking and collaborating with my urologist and with my gynecologist and with my allergist and with my gastroenterologist? Those are fairly few and far between. And in fact, Robert Eckenberg, who is a pelvic pain, probably the top pelvic pain specialist in the country, he practices out of Pennsylvania and New York City. He's devoted his career to that. He's really trying to educate doctors so that we can have kind of a one-stop shop where you've got doctors with a really diverse skill set. I'm a member of Kaiser Permanente, and the nice thing about Kaiser is everybody's electronically connected, and they have a fairly good referral process. That said, doctors tend to be pretty territorial. They don't necessarily want to listen to another doctor. You know, I got a radiologist fired at Kaiser because she was doing avoiding cystogram. She refused to read my urologist's instructions. She gave me a hydrodistension without any anesthesia. I'm laying there screaming my head off as my bladder was distended, double what the doctor said it should have been distended to. And I walked out, you know, shaking like a leaf, and I wrote a letter to the hospital and got a call from the head of the hospital and an apology. And she got her ass fired. She deserved to be fired because she refused to do anything that the urologist told her to do on a urology test. Okay, so just it's a tall order. I'm going to wish you luck on that. It's going to be hard to find somebody who will do that. Hello, Julia, from Italy. Yes. Julia is asking about hyperbaric oxygen therapy. So hyperbaric oxygen therapy it was first done, I think, in Germany. The research studies were good. It basically means being put into an oxygen chamber where they raise your oxygen. You know, I don't ask me about the specifics of it, but the early studies in Europe were quite promising. There was, I think, one study in the United States. It was quite promising. However, we simply did not have centers who were capable of doing it. You're much more capable of doing it in Italy and in Europe. It's definitely more common over in Europe. So I think it'll be very interesting to see how you do about it. I don't know of any bad, hold on, let me look. Let me look for you. I know exactly where to look. Let's see if we can find hyperbaric oxygen. So there's a website called PubMed, and it's the United States National Library of Medicine. And let me write it down for you. I want you to come over here. PubMed.org. So I want you to come over to that website, Julia, and search for hyperbaric oxygen therapy, interstitial cystitis, non-interstitial cystitis. And what that's going to do is give you the research studies for it, but it's also going to talk about potential adverse events. And so literally the third one to come up was somebody who developed pulmonary edema and a seizure during hyperbaric oxygen therapy. Here's one: hyperbaric oxygen therapy side effects, where do we stand? And of course, the full text of the article in there. Yet, hyperbaric oxygen therapy ameliorates osteonecrosis in patients with modulating inflammation and stress. For hearing loss, they're doing it for hearing loss. Isn't that interesting? Sudden sensorineural hearing loss causes substantial disease. Let's just see if, wow, it helped. Yeah, girl, you just got to look through that, see what the dosages are, all that sort of stuff. Okay, there's lots and lots of research studies about it. Sue says, where do you put the TENS unit? Your urethra and start? No, dear God, do not put a TENS unit on a mucous membrane in your crotch. Seriously, Sue, do not do that. This book, Ending Female Pelvic Pain, will tell you where to put it, and it gives you lots of locations where you can do it. If you watch earlier in this, rewatch this lecture, I showed pictures of it. But do not put it on a mucous membrane in the middle of your vulva. Ooh, no, we do not want to put electricity there. That would be a catastrophic mistake. Jolene says she got nauseous every time she looked pre-leave. I believe it. It's possible. You know what? Let me check. Let me check YouTube here for a moment. If you're wondering why I'm looking down, it's just my window for YouTube is down a little bit further. We are simulcasting on Facebook and YouTube. Gypsy, what causes the bloating? The icy belly. I asked Dr. Theoretes that, where you wake up in the morning, you look normally thin, and by the end of the day, you look like you're 6 months pregnant. He believed that it was some sort of inflammatory process. That bloating tends to come and go. I find for me, though, that I definitely bloat more if I eat wheat products, which is why I tend to go gluten-free. Even though I don't have celiac disease, I do much better going gluten-free. I really cut my wheat way down. I make gluten-free pancakes, stuff like that. Eva says, can you please tell us more about muscle relaxing? Well, muscles have a memory. It's called muscle memory. So as an example, I was a very big tennis player in high school and college. I even played professionally a little bit. And I practiced and practiced and practiced for years. So my body is trained. My muscles are trained to hit a tennis ball perfectly, right? And so I trained my muscles. My muscles have muscle memory. So even though I haven't played competitively for 30 years, you give me a tennis racket, I can go out on a tennis court right now and still hit a tennis ball like a professional. My body knows how to move. I trained it. Any athlete trains it. That's called muscle memory. But sometimes what happens is your muscle memory gets reversed. And as an example, if you have long-term bladder pain, what happens is here's your bladder, and your bladder is pulsing, right? Your bladder's in pain. Here's your pelvic floor. Because your bladder is in pain, your pelvic floor is going to get tighter. We call that a guarding reflex. Untreated pain causes muscles to stay tight. And then what happens is they kind of get stuck there. Their muscle memory becomes confused. Their muscle memory thinks that those muscles are supposed to be tight instead of relaxed. Think about it. Look at what that does with my hand, right? When I squeeze it, all the blood flow diminishes and it gets white. And then when I let it go, you can see the blood flow comes back and it turns pink again. That same process happens to your bladder, right? When your bladder's squeezed, it's not getting good blood flow. So, muscle relaxation is all about retraining a muscle to be long and loose and pliant. It's about recognizing behaviors that trigger muscle tension, like sitting for a long period of time, driving for a long period of time, straining to poop, straining to urinate. Those all will reinforce muscle tightness. So muscle relaxation is about avoiding those things which can irritate it, and also about doing exercises and stretches which will lengthen that muscle, which will loosen that muscle, and will also address any tight trigger points. Muscles are really cool because when you think about it, so when you pop a bicep, and you can't see my bicep right here, right? I have my little bicep. I used to have a bigger bicep, but hello, that's a year's worth of recovering from surgery. So my normal muscle length is long and loose. When I pop that bicep, that little bicep right there, that muscle is contracted. So here's the way the muscle fibers work. Your muscles or fibers are kind of end to end. And when you contract them, they slide. And then when you loosen them, they relax again. So this is how a muscle fiber works. When they're contracted like this, how do they stay stabilized? They have little tiny pili that attach to each other. So the muscle slides, and then the pili reaches out, the little fibers reach out, and they anchor those muscles. And then when you're ready to relax, the pili release and the fibers come like this. Sometimes, though, the pili don't release, and you end up with a muscle knot. You end up with a muscle knot. And, when you have a muscle knot on your back, you get a family member or for your friend, and you ask them to push on it. Because when you push on it, it usually triggers it to release. So you could also have muscle knots in your pelvis, internal muscle knots in your pelvis that might need to be released. And that would be something a physical therapist could do. Okay. All righty, let's keep going here. We are at 2 hours and 13 minutes. Kelly says she had her first urologist visit. He scheduled a cystoscopy biopsy on the 19th. He says the cells he biopsies will tell him whether I have IC or not. In Europe, that would be true because they require hydroextensions with biopsies, and they take those biopsy results and they will rate you on a 16-point scale. So if you have Hunner's lesions in Europe, you're a 3C. If you have a normal bladder wall, and a normal biopsy would be a 1A in Europe. In the United States, we don't do that as much. In the United States, in the American Urology Association guidelines, a hydrodistension is not first generally suggested. Normally what they would do is give you the diet, give you step 1, maybe give you a couple of medications, and send you home for 3 months to try them to see if we can create an environment that will support the bladder healing itself. And then 3 months later, if you're not getting better, if you're getting worse, you go back to the doctor. That's when the doctor is going to say, well, maybe we need to take a look. No, we don't normally go right to a cystoscopy hydrodistension because they have to do a hydrodistension to do a biopsy, unless you've got a symptom that they're concerned about. Like if you have a lot of blood in your urine, then that is perfectly reasonable to do. The only thing, Kelly, so I'm not disagreeing with your doctor at all. If you've heard me talk before, I am a person who likes objective information. And if your symptoms are worrisome, if you're in a lot of pain, if you're bleeding, I completely agree that having a doctor look at it is the right thing to do. But as the American Urology Association says, and this is what you need to know, is your procedure should be a low pressure, short duration. They no longer recommend a high pressure, long duration. 20 years ago, when hydrodistensions were common, they believed that more was better. So they would really fill the bladder up with fluid and they would hold it in there for a long period of time. And what they came to see over time is that that was damaging to the bladder. And so in the AUA treatment protocol, their goal is to reduce harm. They acknowledge the fact that many patients never went back to their doctor because they were hurt in their appointments. And so when you look at these guidelines and you read these guidelines, you can see that they're taking extra care not to traumatize the IC patient anymore, not to be aggressive in a harmful, tissue-harmful way. So I would just say, Kelly, that I would have a discussion with him before that and just say, I don't want a high pressure, long duration. I want a low pressure, short duration. I want you to be as gentle as you can possibly be. And the other thing that I would do, Kelly, is I would go over to the American Urology Association website. You all should do this. Let me write this down. I want everyone here to go to auanet.org. In the upper right-hand corner is a link called Guidelines. I want you to click on that link. You'll be on the guideline page. Then I want you to search for interstitial cystitis until you pick up the IC guidelines. I want you to print out 3 copies. I want 1 copy for you, and I expect you to read it. And I expect you to highlight it because these guidelines are fabulous. They're incredibly comforting with pain. They are proactive with pain management. They support the use of opiate medication as an example. So I want you to print out 3 copies of these guidelines, 1 for you, and I want you to read them. And you don't need to memorize them. I want you to read them. I want you to bring them to every doctor's appointment. 1 for your doctor, because has your doctor read them? I'm going to say most probably have not read them. And then I want you to save a 3rd one for an emergency room if you have to go to an emergency room or another doctor or a pain specialist. So a lot of pain doctors simply don't know what IC is. And their answer to patients is often, hey, we don't treat pain in the bladder. It's not that bad. Well, these guidelines, my friend, will teach them otherwise. This is not you saying that. This is the American Urology Association telling them to be compassionate with pain care. So again, go to auanet.org, go to the upper right-hand corner, click on guidelines, get to the guidelines page, search for interstitial cystitis, and read those guidelines. You know, what's really cool about them is you've got all the research citations right there. So no doctor can say, hey, I'm not going to listen to anything you get online. What you're going to say is, no, this is from the American Urology Association. This is what I want to do. I want to follow their guidelines. And their guidelines, Kelly, are very clear about hydrodistension. And so it would be very interesting for you to have that information. Mary Jo says, do you take supplements like Sister Renew on empty stomach or food? I always took them with food because if I didn't, my stomach fluttered a little bit. I don't think it really matters. Lucy says, which supplements you should try, hun? It's a guess. It's a guess. Well, so Sherry says, if IC is irritated by acidic foods, and why don't treatments focus more on polycitric A and similar drugs? If you read the AUA guidelines, you'll see that they do. They suggest using polycitric K. It doesn't come up that often, but that's not necessarily going to fix the problem. It's going to reduce the acid level so your bladder's not irritated, and it's not interfering with healing. But that doesn't necessarily mean that an acid-reducing product is going to heal the bladder wall. Marika says, can I take fish oil? Can I take Sister Renew? I don't know. It says this product contains no yeast, gluten, soy protein, milk, dairy, sodium, sugar, starch, artificial coloring, preservatives, or flavoring. It does not say that it has fish in it that I can see. Whereas Cysto Protect does have shellfish in it. But Cysto Protect says it is fish or fish. Cysto Protect contains natural ingredients and is free of milk or milk byproducts, egg or egg byproducts, fish or fish byproducts, tree nuts, peanut byproducts, wheat or wheat byproducts, soybeans or soy products. I thought that one of the ingredients was derived from shellfish, though. You know what? Hold on. Warning for Cysto Protect. Do not use if allergic to shellfish. Okay, so you cannot use if you're allergic to shellfish, you cannot take Cysto Protect. Sister Renew does not have that warning on it. And to double check, I would go over to Douglas Laboratories, and you can search Sister Renew on their website and see if they have any additional warnings on there. I'm not aware of any additional warnings, but you got to do your own work, girl. You got to verify it yourself. Hi, Cheryl. Karen, you can watch this video again. All the videos are stored on the Facebook page and on YouTube for a while. Thank you, Susan. This is actually not an ICA support group meeting. This is an IC network, the Interstitial Cystitis Network support group meeting. There are two national organizations for IC. There's the ICA and there's the ICN. The ICN started out, I was originally an ICA support group leader back in 1993, but I took a very strong interest in trying to provide a way to bring support to patients who are homebound. And I was really captivated by that. I had very, very severe patients in my group who were not coming to support group meetings when I knew they needed to be there. And I would call them and ask them, why aren't you at the meeting? And they said it hurt to get in the car. I could relate to that because it hurt me to get to the car. I would literally drive to the hospitals that I was doing them at with in pain, in a lot of pain. And so I got online and was really fascinated by the concept. How can I bring support to them? And that was when America Online and CompuServe were very new. And I started the first urology support groups on both of them. and worked with paraplegics, quadriplegics, IC patients, prostatitis patients, infection patients, cancer patients, worked with all of them. And then I had a year's worth of data, pitched it to the ICA, said I would love to build you the first website on IC and the first online support center. And they laughed and said it would never work, said that I got a lecture on knowing my place, that I was a support group leader, that I shouldn't have big ideas like that. And I offered to do it for them for free as a doctoral dissertation, and they were not interested. And I said, okay, if you don't want to do it, then I'm going to do it on my own. And that's how the IC Network was born. And the IC Network has now been rated #1 in 2 major research studies on the accuracy of information online from Harvard Medical School and the University of London. We are the first to do online support groups, and I'm very proud of that. I'm proud of our work 25 years later. You know, every group has its place. The ICA is very good at lobbying, whereas the IC but they're now run by a for-profit firm. So they've kind of distanced themselves from patient lives, whereas we are IC patients, and our focus has always been on support for 25 years. And as the executive director, as the founder of the IC Network and as president of the IC Network, as the editor of most of our materials, I'm writing it from the perspective of what a patient needs to hear. And so that's really how we're different. Is they're a little bit more academic. We're just more grounded in day-to-day life as an IC patient. But we're still very, very academic. So, I have 3 degrees, and I use them all the time. I also, as I said earlier, October is the month where we start our U.S. Army IC research panel. I've been sitting on the U.S. Army congressionally directed medical research panel for IC research for years now. And we just got our assignments again. I'll be reading these new studies on Monday, tomorrow. And we get to decide, I'm a full voting member with all the researchers, what projects get funding. And so that brings another level of perspective to my work on the IC Network, is I have the opportunity to work with the best and brightest IC researchers, and have for quite some time. Our medical boards are also pretty identical. So one other difference, they're a nonprofit. We're a health education company. We are not a nonprofit. We are a philanthropic for-profit. That means we give 99% of what we do away for free. But the way we pay for this is through magazines like our membership and through items in our store. When the IC Network set up, I paid it for myself for the first 5 years, ran out of money. We needed an income source, but there was no grant money for nonprofits. So we organized as a health company instead, a health education medical publishing company. We are the largest IC support group in the world with well over 50,000 members. So we are doing well. Unpaid members, not paid members. Our paid membership is much smaller than that. All right. Thank you, Jolene. Sister Renew, Mary Jo, I would actually do it with a little bit of food. Yeah, JJ, that was Sister Protech about the shellfish allergy. Sister Renew does not appear to have a shellfish allergy warning on the bottle, but I would double check that on their website. Jennifer says, what is my opinion on Uribel? I think that if it's helping you, great. If it's not helping you, move on. I don't have a strong opinion on Uribel. Karen had a potassium sensitivity test. That's an old way of checking to see if the bladder wall is damaged. We don't really do that so much anymore. Now we do something called an anesthetic challenge. If you put salt on an open wound, it's going to hurt. Potassium salt in the bladder, in an IC bladder that's a damaged bladder, is going to hurt. That's how we distinguish if the bladder wall is damaged or not, but it is profoundly painful. And so it was Dr. Robert Muldoon who said, well, wait a second, rather than doing something that will trigger bladder pain, why don't we numb the bladder instead? If we put a numbing agent in the bladder and the bladder pain goes away, we can draw the same conclusion that the bladder wall is dysfunctional. And so far more doctors now do what we call an anesthetic challenge rather than a potassium sensitivity test. The potassium sensitivity tests have been kind of challenged in research in quite a few ways as being not necessarily reliable, whereas the anesthetic challenge, I think, is more accepted these days. Christy asked, what causes Hunner's lesions? Boy, isn't that the $6 million question? We kind of have two theories on Hunner's lesions right now. We believe that Hunner's lesions are a nerve, that there is a nerve that is profoundly inflamed. And when a nerve becomes inflamed, it releases a substance called substance P. And substance P is damaging to tissue. It causes wounding. And so one theory is that Hunner's lesions are a nerve that is profoundly irritated. And I have a graph of this that I can, well, it's kind of, well, okay. Okay, this kind of explains it, but this is really about a bladder injury also. So this is in our summer IC Optimist, which is our membership magazine. Okay. And I went to the American Urology Association conference where there was a class on chronic pelvic pain taught by Dr. Robert Evans and Robert Moldwin and Jennifer Fariello. It was an outstanding class, and I summarized it in depth in this magazine, really how doctors should be treating IC today. And this is one of the graphs that they showed. And so let me see if I can show this to you. I don't know if you can really read that or not, but here's what happens. So the top here, we've got a bladder insult or a bladder insult. Something has damaged the bladder. Let's call it chemotherapy. When the bladder gets injured, the skin is damaged, epithelial layer damage, right? And when the skin is damaged, urine, including potassium, leaks into the skin. And when it gets into the skin, it irritates nerves. It activates the nerves and the release of substance P. And then when substance P comes out, substance P also causes mast cells to release histamine. And then you get stuck in a vicious cycle right here. You get nerves irritated, causing mast cells to release histamine, and that then triggers more nerves, and then that triggers more this. So when you see the AUA guidelines and you see treatments, you see an antihistamine and you see a low-dose antidepressant, because the low-dose antidepressant, Elavil, calms the nerves down, and the antihistamine calms the mast cells down. But if these are not treated, you get stuck in this vicious cycle that then causes more injury, more bladder damage, more epithelial dysfunction, more leaking into the urine. You get it? You get stuck in this loop when you have a bladder wall injury. And you kind of get stuck in this loop when you have a Hunner's lesion too, because you've got an open wound. Urine is going into the wound. It is triggering irritation in those tissues, which is irritating nerves. So theory number one on Hunner's lesions is that it's a nerve that is stuck that's massively inflamed. Theory number two about Hunner's lesions is that it might be a virus living on that nerve. We now have a couple of research studies which have linked viral infections to Hunner's lesions. And it was researchers in Switzerland who made Switzerland, or one of the small countries in Europe, they found the polyoma BK virus in the urine of patients with lesions, but not in the urine of patients without lesions. The polyoma BK virus is a virus we all have. It is a natural part of the urinary biome, not a sexually transmitted disease. You shouldn't be thinking that way in any way, shape, or form. The polyoma BK virus is a silent virus. It is normally not turned on. The only time it gets turned on is if a patient is really immune compromised. And you'll find at the National Library of Medicine lots of research studies linking polyoma BK to hemorrhagic cystitis, especially in patients who are on steroids for organ transplant. So we've got the polyoma BK, and then 4 months ago, we also had a research study that linked the Epstein-Barr virus to Hunner's lesions. So There may come a time when lesions may be treated with an antiviral if you have a positive viral test. And you can, and in fact, in Europe, they screen for viruses as part of that diagnostic workup. That is not something that is done in the United States. And in fact, I sent out an email 2 weeks ago to a counterpart in Europe, and I asked her, how do they treat viral infections? And the answer was they really haven't done the research to do it. There may come a time when we may be doing an antiviral for patients who have viral infections. Next generation DNA testing can screen for viruses, but it's not the normal screen. You actually have to call the company, and it's a different test. But I think it's interesting. So much more to come on that. The other thing to know, Christy, about Hunner's lesions is we have the first treatment in history that has healed lesions in 2 weeks. It's called Liris. And this is interesting. So what's the fundamental problem with bladder disease is how do we get medicine to it, right? How do we treat, any medicine we put in the bladder, you're going to pee out within a couple of hours at the most. So trying to treat a bladder disease with medicine is really, really hard. So researchers at MIT tried to solve this problem by building what we call a drug delivery device, a device that will deliver medication. And so imagine a soft, hollow piece of spaghetti filled with medicine. And that's what they did. It's called Liris, the lidocaine pretzel. So it is a small tube that they filled with lidocaine, and you put it in the bladder where it kind of folds up on itself so it won't come out. And for 2 weeks, it will deliver medication 24 hours a day, 7 days a week to the bladder. It was originally created for bladder pain. And that's why they chose lidocaine, because lidocaine is a numbing agent, right? So in the first research study done by Curtis Nickel up at Queen's University in Canada, I think they had 15 patients in that study. They did hydrodissensions before and after. And so about 6 or 7 of those patients had confirmed lesions before they had Liris treatment. They were stunned to discover at the end of that trial that every single one of those lesions had healed. They were gone. The language in the research study and the research results, it was published at AUA, was a complete and total resolution of the lesion. Stunned. Everybody stunned. Nobody thought you could ever treat a lesion and heal a lesion until Liris came out. And I had my first patient call me who was in that study who said, "Oh my God, Jill, my lesions are gone." And I called the company and they went, "Yeah, the lesions are gone." But we couldn't talk about it for a year until they published their data. And they did publish their data at the AUA conference. And yeah, that's what happened. So that kind of confirms the neuromodulation. I mean the neuroinflammation theory, because what does lidocaine do? It turns nerves off. So if you silence the nerves for 2 weeks and the lesions go away, that kind of makes you think the lesions are being driven by nerve activity. I talked with the research director for Allergan who bought it, and he had another explanation for that I don't remember. But anyway, so if you've got Hunner's lesions here, there's every reason to be very optimistic and hopeful because we now have a treatment that is healing them for the first time. And now we're just waiting for research studies and FDA approval. And they've done many research studies, and we're waiting for the next round of research results right now. But it's very exciting. And I have worked with patients who have had the treatment and their lesions have gone away. And in some patients, lesions get smaller. If they had 5 lesions, it might go down to 2 lesions, or the lesions go away. So it's really, really exciting. Okay. All right, let's go. All right, guys, last call for questions. Julianne, many Irish doctors are prescribing long-term low-dose antibiotics. Yeah, that's a real tragedy because what that's doing is that's creating an environment that will facilitate drug-resistant infections. And you can see from the American Urology Association, they do not recommend the use of long-term antibiotics. I would really suggest that you print out the AUA guidelines, print out many copies and hand them to them, and then just say, listen, we know every country's different. We know every country's approach is different, but they make a very compelling case for not using long-term antibiotics unless you have something like this, which finds a funky chronic infection. And then in that case, it's about targeted antibiotics rather than a broad spectrum antibiotic. And for God's sake, it should not be Cipro. If it is Cipro, at least Google Cipro FDA alert or Cipro alert. Cipro has now been linked to really serious adverse events. So Cipro is not used unless other medications don't go there. Julie says the link between IC and Epstein-Barr, your primary doctor doesn't understand the connection. It's a viral infection. It's a viral load infection. And if you, I have the research study in here. Let me see here. Page 14 of the IC Optimist. Epstein-Barr virus implicated in Hunter's lesions. And so I would order a copy of this magazine or become a member, and you can give him that, and then that will show him how to look at that study. And again, that's not the first virus. Thank you, Laura. Hey, guys, 25 years studying, I see. What is the time frame for healing after that treatment? I'm not sure what treatment you mean. Listen, I can promise you that healing is happening. If you fell and skinned your knee, you would have a scab on it tomorrow. The human body is wired to repair itself when there's damage. The challenge is sometimes it's not the damage you think it is, and as an example, I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? For us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved to some degree. And let me explain why. So for some patients, IC begins after a direct bladder injury, like chemotherapy, okay, or drinking diet soda. Oh, and did you see that research study we presented about, they've now proven that artificial sugar messes up your biome, your bowel biome. Another reason not to do artificial sugar. Okay, but getting back to this. So let's just say your bladder wall gets irritated somehow. You have pelvic floor muscles that are protecting you, right? The pelvic floor muscles support the bladder. They act like this. So here's your bladder. Here's your pelvic floor. Your bladder is pulsing in pain. So what does your pelvic floor do? Your pelvic floor gets tight to protect it. That's the way the human body is wired. It's called the guarding reflex. For these patients, our goal is to calm the bladder. Because when we calm the bladder and we stop it from pulsing, the muscle should release, right? So for these patients, if you're having a bladder wall flare, our objective is going to be to calm and soothe the bladder. However, think about the opposite scenario. What if you're one of those patients where your IC began after having a baby or falling on your tailbone or riding a bike or a pelvic injury or a rape or something like that? Okay, so here's your perfectly normal bladder and here's your muscles. But your muscles have been injured. And an injured muscle becomes a weak muscle. But muscles have a job to do. So for them to do the job, they get tight. So your muscles get tight over your bladder, and they get tighter and tighter and tighter. And if I release my hand, look, you can see what happens when I squeeze my hand. There's not a lot of blood flow, right? And it takes time for that blood, a fraction of a second, but it takes time for that blood to go back. So tight muscles restrict blood flow. Now, of course, you really didn't know you had a pelvic injury, and your first symptoms are frequency, urgency, right? So you think you have infection. You call the doctor. The doctor gives you antibiotics. They don't work. Then the doctor goes, well, maybe you've got overactive bladder. They put you on diazepam or Detrol for months. They don't work. Then you get diagnosed with IC. They put you on IC meds like Elmiron. None of those work for you because your fundamental problem is not your bladder. Your fundamental problem are tight muscles. So our goal with these people is to restore blood flow by relaxing muscles. When you restore the blood flow, then the bladder can get the oxygen and the nutrients that it needs to heal. Now, of all the therapies ever studied for IC by the National Institutes of Health, the single most effective study was the pelvic floor physical therapy study in 2008 when that was released. And when that study came out, that turned the IC world on its head because up to that point, we were all thinking IC was bladder disease. Then you have to ask a question. Well, if it's bladder disease, why would muscle therapy work? And it's like, oh, wait a second. Maybe it's not bladder disease for some people. Maybe it's muscle trauma for some people. And so now that we're subtyping, I mean, we've come so freaking far from 25 years ago when we thought everybody was the same. Now we know that they're not the same. Now we know that there are subtypes. Now that we know that there's distinct variations in the IC patient population. If you are in that population where your symptoms began after a muscle trauma, whether you were a paratrooper jumping from planes, or whether you were a gymnast or an ice skater falling, or whether you were sexually abused, or you were in a car accident, your presentation of IC is very different from somebody whose IC who began from chemotherapy or a decade of drinking diet soda. And we're going to treat you very, very differently. And that is why these subtypings are so incredibly important. If you come to our website, I have a video series called the Living with IC video series. There are 3 videos, well, 2 videos everybody should watch. And that is the 5 subtypes of IC and the 6 steps of treatment. And then there's a 3rd video for women called the Estrogen Chat. I want you to watch all 3 of those videos because they will give you the foundation of knowledge about how we're treating IC today. Okay? Lisa says she saw an old interview with Dr. Therides where he said for severe symptoms, you can take 6 versus 4. I don't know if it's old news. If he said it, he invented it. It's just not what the packaging says. And again, now that we know this central sensitization subtype where we've got a subgroup of patients who are drug sensitive, more is not necessarily better for those. All right. Okay, my friends, listen, if you found this helpful, would you please come over to our website and become a member of the IC Network, and so that you can get these magazines, so that you have all this information, because this is great ammunition to use as you're seeking medical care. It's $25 a year, $50 a year, $100 a year, your choice. You pick the one you want. And just go over to the IC Network and you can click on IC Optimist or memberships or go to the shop. So if you found this helpful, your membership makes this chat happen. Your membership has literally made the IC Network the #1 website according to Harvard Medical School. Okay, so thank you for those of you who are members. And if you're not, please come be a member. You're always welcome to call me. Also, I work with patients all the time, every day, pretty much all day, which is hard for me to get my new content out. I'll tell you that much. You can call us at 1-800-928-7496. We're the only IC group that answers the phone. I work on a first come, first served basis every day. I usually start taking patient phone calls around 11 in the morning Pacific time. I will often go until 6 my time. If you're on the East Coast, that could be 9 your time. I try not to do that. However, if you do get my answering machine, it means that I'm already working with patients, so you will be dropped into the queue. Sometimes it takes a day or 2 days for me to call people back, especially after meetings when we get lots of phone calls. All right. But just know I will try. I do my best to try to help you because I'm an IC patient too. Now, of this entire meeting, there's one point that I really need you to remember. And that is, this is not your fault. You have done absolutely nothing wrong. There is no shame. There is no blame. I don't want you to carry any burden on your shoulders like I did in my 20s when I did not understand what the hell was wrong with my body. Okay? You are capable of being a husband, a brother, a son, a wife, a sister, a mother, a grandmother. IC does not change the love that you have in your heart. It does not change your spirit. It does not change your soul. It does not. Don't let it do that. It is below the waist. Try to keep it there. Okay. But every day I need you to do 3 things. You know, I don't expect big things. Asking a patient to do something big is really unrealistic. It's hard to do big things when you're in pain. So I want you to do 3 small things every single day. Number 1, I want you to do something for your soul. Do 15 minutes that will give your spirit and your soul comfort. I don't care what it is. It could be touching a redwood tree. It could be going to church. It could be watching Joel Osteen, whatever you want. Do something that gives you comfort. Then I want you to do something for your body to make your bladder feel better and to make your body feel better, whether it is doing your stretching for pelvic floor, whether it is taking a warm bath, whether it is saying no to coffee like I did yesterday. Oh my God, I wanted coffee so bad yesterday. This is my coffee-free year. And I almost did it, but it's my resolution. I figured, listen, I'm 10 months out. I can make it another 2 months without coffee. So 1 thing for your body. And then I need you to do 1 thing for your brain to work on your education about IC. I want you to come to our website and read just 1 section or 1 blog. Okay. And slowly over time, that is going to get you to where you need to be. It's going to give you comfort. It's going to give you knowledge. And I really hope that it gives you, it builds a nice, slow foundation of healing physically, mentally, and emotionally. I say that because I was profoundly depressed in my 20s. I mean, I had polycystic ovarian disease. I had vulvodynia. I had low thyroid. I had migraines. I had irritable bowel. I had food sensitivities. I had drug sensitivities. I didn't know what the hell was wrong with me, and I thought it was my fault. I thought I was damaged goods. I thought I was unworthy. I went through a period where I actually didn't believe that I deserved to go out with my family to a restaurant. Plus, food hurt anyway. And I had very, very, very dark thoughts. But then the research came out. The research came out showing a genetic connection. That was from the University of Maryland. And I am IC subtype 5, central sensitization, which is the related conditions to IC. And I looked at my family and went, oh my God, my sister has this, my mother has this, my grandmother. It was never my freaking fault. And when that research study came out, I'm going to tell you the weight, a ton weight on my shoulders melted away. And I became a much happier person because I've done nothing wrong. And you have done nothing wrong. And I don't want you to carry any shame or blame. What I do need you to do, though, is to be proactive. I don't want you sitting at home, suffering in pain, crying. I need you to kick some butt, including your butt. Don't give up, for God's sake. Don't rely on what somebody said to you 20 years ago. Don't come to the internet and go to Facebook and read everybody's bad stories. Remember, support groups are always biased towards patients who are struggling. And they may have a completely different subtype from you. Anyway, don't be, so if you're fragile, if you're emotionally fragile, depressed, please don't come online. Remember that for every person online who's having a bad day, there's 1,000 having a great day. You got to keep it in context, my friends. Keep it in context. All right. So listen, I'm giving all of you, listen, if you find yourself wavering, I want you to pretend that I'm standing right in front of you saying, stop, it's not your fault. And then I'm going to give you a big giant hug afterwards because it's not your fault. It's not your fault. You're no different than someone who was hit by a car and or somebody who may have inherited something like I did. Okay. All right. I see one last question here. The question from Toronto is hematuria the same as Hunter's lesion? The answer is no. No, it's not. And it's a very, let me explain it. It's really interesting. So let's look at this. Let's look at this picture again. So you got your bladder coating, you got your epithelial cells, you got your nerves, and then you got blood vessels. See these channels right here? Those are blood vessels. So when you don't have coating and urine gets in here, you've got molecules and irritants deep in the bladder wall that don't belong there. So what does the human body do? I mean, I always think that we as people, we are remarkably arrogant in thinking that we're smarter than the human body, and we're not. The human body is amazing. So somehow these cells communicate to the brain that something is there that shouldn't be there. And the body responds. The body responds by sending your fighters, your white blood cells. And it's your white blood cells that go in and kill bad things. So they are mobilized. I don't know exactly where they're mobilized from, right? But they're produced by bone marrow, I'm pretty sure. So you've got this army of white blood cells coming to this area. And they arrive through blood vessels, right? So here they are in the blood vessels, but the irritant's up there. How do they get from there to fight it? And the answer is the blood vessels open. The blood vessels, the little tiny capillaries, release them. But so it's delivering the white blood cells exactly where they need to be outside of a blood vessel. But when they open to release the white blood cells, they also release red blood cells. And that is why many IC patients, when you go to the doctor and have a urine test, you've got microscopic hematuria. You've got blood vessels in your urine. And that is a normal, natural part of the process of how your body attacks problems in the bladder. So a hematuria is absolutely not the same as a Hunner's lesion at all. Now, if you've got visible blood in your urine, that's a concern. If you're peeing blood clots, you need to call the doctor. If you're peeing pink, your toilet is filled with pink urine, you need to call the doctor. That needs to be investigated. Most of us instead have microscopic blood in our urine, which you cannot see, and that's usually not a concern. But if you've got a pink toilet or you're passing blood clots, that's a perfect example of making sure you're tested for infection. Let's make sure there's not an untreated infection happening, and or that could be Hunner's lesions bleeding, because Hunner's lesions bleed profusely, and that's when we would ask for more testing. Definitely a urinalysis, aggressive urine testing. If it's still bleeding, got to do a hydrodistension, take a look in the bladder, try to figure out what's bleeding, because bladder cancer also bleeds, right? But that's, again, visible blood. If you're like me, I will tell you, the year that I was diagnosed, I was obsessed thinking I was dying of cancer because my pain was so severe. I couldn't fathom that it would not be cancer. And I didn't believe my doctor, and I demanded exploratory surgery, and they did it. So I had surgery as part of my diagnosis. I demanded it. I said, I don't believe you. You have got to have missed something. And it turns out you can also do a very simple urine test called a urine cytology test, and they've probably already done it. It's just a normal routine test. But if you're one of those people where you're just thinking, and it's kind of, eating away at you, maybe it's this, maybe it's that, especially if you've got blood in your urine, for God's sake, just have the test so you can stop worrying about it. There's absolutely no connection between IC and bladder cancer. Okay. Let's see here. Cheryl says, will Sister Renew help with my Hunner's lesions or pelvic floor pain? Probably not. Although the Sister Renew, that might reduce some of the histamine activity, make give you a little bit of a coating. But generally, Hunner's lesions require Hunner's lesion specific therapy. And of course, the supplement is not going to help a pelvic floor issue. That girl, if you're having pelvic floor pain, you got to do a muscle relaxant. Talk to your doctor about, maybe you can try some Baclofen or Flexeril to try to get your muscles to relax. And that might be far more effective than a pain medicine anyway. Baclofen is non-sedating. It's really the first one you want to try. Or Flexeril, which is sedating. You would take it at night before you go to bed. I take a quarter of a Flexeril when I have pelvic floor spasms, and I'm having one right now on my left butt cheek. It is vibrating from I've been sitting too long. Oh, Lori, Robin, Trisha, you just came, and I'm so sorry. It's been 3 hours. We are just finishing. All right, my friends. I wish you well. I hope that you sleep well tonight. I hope that you have a wonderful week. And you know where to get me. If you have questions, I'm more than happy to try to help. All righty? Okay. I'll talk to you later. All right, YouTube. Last call on YouTube. Facebook is shut down. Any last questions? Julianne says, here's hoping DNA Next Gen urine testing comes to Europe soon. You know what? They are getting ready to do international testing. I just talked with them about it, and it will be activated soon on their website. So it will be available to patients in Europe. Alrighty. I just don't know quite when, but I think it's going to be sooner rather than later. Alrighty. All right, my YouTube friends, I wish you well. See you later.